Assalamualaikum.
وعليكم السلام.
How are you, doctor?
الحمد لله fine. الحمد لله دكتور برفينا I am fine. الحمد لله.
Doctor, I want to ask you something
Yeah.
before we start our class.
Yes.
Do you have, doctor, the flow charts of all the GTD and all in one PDF?
Yeah. I had. Yeah. Yes.
Can you please
Yeah.
send me?
إن شاء الله دكتور برفين إن شاء الله. السلام
Thank you.
عليكم.
Jazakallah.
السلام عليكم. Good evening, everybody. We will continue our journey in the revision in Dr. Fath Rahman about MRCOG Part 2 exam. Our exam is very near, alhamdulillah. We did our best. All prayer, inshallah, all will clear this exam. Pray and pray, all will clear, inshallah. Today, we had a mock exam. We will do first the mock exam. And after that, I will open the discussion. If you want to, first we'll open the discussion and we'll see whatever a doctor want will explain, or better, no voice. From the start, no voice. Okay. Or you want to finish our mock exam and after that we'll open the discussion. What you want, we will do. Which is better, I think.
First, we will do mock.
Yeah, first we'll do the mock exam, and I need your participation. It is open discussion. Any point not clear in the question, better will clear. With the guideline, with evidence. So it will be very benefit for all of us. At the end, if you had any query, any problem, we'll explain. Okay? Yeah.
Yes, ma'am.
Yeah, Bismillah ar-Rahman ar-Rahim. Let us start. Who will share? Who will start? The first question, I need your participation and I need active discussion, so you'll get more benefit.
I will read, doctor.
Yes, start. Bismillah.
But I'm not sure with the answers, okay?
No problem, we need open discussion. Only we need not the correct answer. We need anything around the question. Yeah, this is our aim here today. So we can touch most of the guideline.
Yeah. A primary gravida at 38 plus 6 weeks of gestation is admitted with a history of abdominal pain and clear like a leaking vaginally for 5 hours. There has been no other risk factor in her history. On examination, her observations were normal. She is having regular painful uterine contraction in 3 in 10 minutes and cervical dilatation is found to be 4 centimeters. CTG was performed due to the concern about the fetal heart rate on auscultation. The CTG shows a baseline of fetal heart rate of 140 to 150 beats per minute with no other non-reassuring or abnormal features.
Okay. Here the patient, she is Dr. Pervin, she is 38 week plus 6 and she had leak. All the time, remember leaking, we are afraid from infection. But here her observation vital sign, it is okay, and I see her contraction also, it is adequate, 3 in 10. So what we will do? And the patient low risk. Remember, if the patient low risk, it will be intermittent auscultation. If patient high risk or any indication for continuous fetal monitoring, we will do. Our patient here low risk, and before there is concern about the CTG, so they attach continuous fetal monitoring. Usually, if you had concern about the CTG, about any problem, you will do continuous 20 minutes. After that, if normal, you will come back to your regular follow-up. We will see the option and you will tell me the answer.
Okay. Augmentation with oxytocin, cesarean section, continuous CTG and normal care. Immediately perform fetal blood sampling and tocolysis.
Yeah.
Continue CTG and do normal care?
Yeah, yes, correct. Because augmentation, you'll think around the question. Augmentation is oxytocin, no need. Because she has the 3 contraction and painful contraction in 10 minutes. It is good. Cesarean section, no need. I will do cesarean forward because the patient is still. Immediately we inform fetal blood sampling, no. Because if I will do blood sampling, that means I had pathological CTG. Tuberculosis, I had no high tachysystole. So the correct answer, it will be continuous cardiotocography and normal care. And usually, if you had concern about the CT, about fetal heart, the patient low risk, and you continue CTG, you will see you will not continue after. Usually, we'll do 20 minutes. If normal, everything reassuring, you can go back to intermittent reauscultation. It is okay like this. Yeah, correct. Yeah. That is good.
Second, a 26-year-old Gravida-2 Para-1 woman with low-risk pregnancy present at 41 weeks of gestation in spontaneous labor. She was transferred to labor ward from the birth unit as she was pushing for 2 hours and yet not delivered. She had a normal progress in labor to date and no CTG concern on arrival. Findings are vital signs are normal. For abdominal examination, less than 1/5 palpable. Vaginal examination is fully dilated, presenting part at spine. Right occipito-posterior position, caput 1+, and molding 1+.
Yeah. Yes, your patient here is a mentioned patient low risk, Dr. Bervin, and she is 41 week. Also, it is okay, and they transfer the patient because she has this one. Usually, the most important reason to transfer here delay in the first and second stage of labor, and also this is a recall question.
Yeah.
Yeah. Here's the option. What you have.
What would be your preferred line of management? Cesarean section, instrumental delivery in room, trial of instrumental delivery in theater, wait for 30 minutes, wait for 1 hour. Trial of instrumental delivery in theater I will do. Because
Why trial of
she's,
delivery?
because the baby,
Dr. Bervin, yeah?
say doctor.
Yeah.
Because the station it at spine
Yeah.
and right occipito-posterior position.
Yes, yes. So you will try instrumental delivery.
At scale spine, yes.
Yeah.
Zero station.
Yes. Remember new guideline, doctor. We had 3 hours. If we had nulliparous, we had 3
Yes,
hours.
ma'am. She was pushing only for 2 hours.
Yeah?
Patient was pushing only for 2 hours.
Yeah. 2 hours.
Not
yes,
he
because
not past 3 hours. So it's not urgent to deliver it right now.
They tell you in the question.
No, she's a multi.
They tell you she is bara one.
She's a
multiparous. You remember?
Holding it is only 1+, and capit is also 1+.
No, the caput no problem.
She's a multigravida. Maybe only 2 hours for her. No?
Multigravida. Remember the new guideline. They mention for nulliparous, it will be 3 hours with epidural, but without epidural 2 hours. And multiparous with epidural 2 hours. Without epidural 1 hour. So her time it finished. You won't interfere. And the head is still for who you high, not low.
I'm forgetting
So, in the room. So it is justifiable to do this one in the theater. Remember the new guideline. Don't think about the other one. And you had no epidural here, Doctor. Right?
Yeah.
Right, ma'am. Actually, I've forgotten G2P when I was taking her as training.
Multiparous. Remember all the time your patient it is nulliparous or multiparous. And remember new guideline. Less hour. If she complete her hour, you need to interfere. You will not push more, but after that it will be more caput. You cannot interfere. This is a suitable time now. Yes?
Yes, ma'am.
Yeah. Okay.
A 75-year-old woman who is para-2, present with low abdominal pain, bloating, and weight loss. Pelvic examination revealed 7 cm pelvic mass and a normal size mobile uterus. Obviously, RMI we have
elder. The bloating is not a good sign. You can think about the malignancy, the most important thing here. And she had pelvic mass. What you will do? Yeah, what you will do? First, your first assessment. For Bergin all the time, don't think about anything. The patient she had only mass. The first assessment, what you will do?
Primary ultrasound already done.
Ultrasound done? No.
It's not done.
Not done. Examination.
No ultrasound.
Is under examination. She has.
Okay.
7 cm pelvic mass.
Ultrasound we will do.
Yeah, but how examination reveals 7 cm?
Sorry.
maybe by only examination.
Yeah, doctor.
Only examination. Ultrasound not done. And she's elder, 75 years.
No.
Yes, I want to.
So we will do ultrasound.
Yeah,
Ultrasound.
ultrasound. Because elder patient and she had polluting. I am thinking maybe she had cyst, she had some malignancy. So the most important for me here, CA 125, it is the option, or ultrasound transvaginal.
Yeah.
Transvaginal ultrasound not optimum. I can to be complete by abdominal ultrasound. So your correct answer, it will be ultrasound first. CT later. I had problem. I measure the risk of malignancy index, and it is more than 100 or 200. After that, I will do CT and refer. But here, this initial assessment, all the time, be systematic, be organized, so the answer, it will be correct. Yeah.
Yeah. A 57-year-old woman has finished her primary treatment with chemoradiotherapy for the stage 3A cervical cancer 3 years ago. She now presents with lower abdominal pain and loss of appetite.
Yeah.
Recurrence.
Cervical cancer, Dr. Barvin, remember me. Cervical cancer stage 3A. Tell me what is there in 3A. Remember us about stage.
Lower
can get more benefit. Yeah.
Lower part of the uterus, then it will be involving
lower 1/3 of vagina.
Yeah.
It will involve
third of the vagina without no pelvic involvement.
Yes, not reaching to the pelvic wall.
If you will go 3B, it will be pelvic side wall involvement. If you had 3 all the time, I am remembering you 3C, the involve of lymph node. It will be para-aortic lymph node and this one aortic lymph node. So what we will do here?
Pelvic.
Here what we will do, this is our option. What do you think about the question? Go back to the question. What is the problem?
Which imaging modality?
He had finished primary treatment and she come back. That means what? Recurrent. Remember the recurrent? What I will
recurrent.
Do? Yeah, recurrent. What I will do, the investigation for recurrent cervical cancer.
PET scan. PT scan.
PET
CT.
PET scan.
The recurrent visual scan.
Which one? Your answer?
C.
C? Why C?
C. PET scan.
C.
Because it is for recurrent
recurrent I will
PET.
all the recurrent I will.
Hello, Dr. Husnia. How are you? PET scan.
Beautiful. How are you?
Alhamdulillah. God bless you. I'm fine. Alhamdulillah, Doctora.
Continue revision till the last hour, inshallah.
Yeah.
Inshallah. Yeah. After today, daily will be the recall. Remember the recall, very important. Wallahi,
okay. Yeah, very important.
From the exam, from the recall.
Maybe
so
more
the
questions
recall
or
daily.
recall.
If you want 4 hour recall, I will do. No problem. Yeah.
Okay.
Yeah, till here, we had recurrent for this one. The answer will be
MRI.
yes, MRI here. Here the MRI. Because you will see the what is after that, if you had recurrent, how you will treat? Anyone to tell me how you will treat if you had recurrent? Yes, because Dr. MRI here is first MRI here. If I am usually yes, I am thinking about the metastasis and
radiotherapy, doctor. Radio.
Yeah, if she received radiotherapy
Doctor,
before,
I thought
yes, radiotherapy, okay. If she is not received, if not treated before by radiotherapy, she will receive radiotherapy. If she receive, I will give other options. Yeah, and if she had it, I give for her excitation also. Yeah, correct.
Dr. Husnia, I thought the answer, because of checking the recurrence, I thought it's PET scan.
No.
It's not PET?
No. Here it is MRI.
So PET in which cases, Doctora? Can you just briefly say PET?
If I had more extension.
Uterine sarcoma.
Remember this sarcoma.
For sarcoma?
Yeah.
Okay.
Also.
Okay.
But here, the first thing you will do MRI.
Okay. But here for cervical, okay, MRI. Okay.
A 38-year-old woman attended colposcopy clinic after a smear test shows severe dyskaryosis. On examination, 3.5 centimeter suspicious looking lesion on her cervix is biopsy. Histological confirms squamous cell carcinoma.
She had dyskaryosis and histology confirmed squamous cell cancer. See the option.
Which next step would be the most appropriate for staging? Examination under anesthesia only. Examination under anesthesia, TVS, CT, chest and abdominal and pelvic. Examination under anesthesia, MRI, pelvis and CT scan, chest and abdomen. EUA plus CT chest and abdomen and pelvis. MRI, pelvis, CT chest and abdomen.
Remember, Dr. Pervin, they ask you what most appropriate for staging. You read most appropriate. Because all the time, read the question again and again. You will not miss any point. Here, if you'll tell you staging, first it will come to me examination under general anesthesia only, right?
Anesthesia.
But yeah, they ask most appropriate staging. I will think about everything. MRI, it will help you in the mapping, the tumor. Extended where, reaching the bladder, where. CT chest, you will see there is distal metastasis in the other pelvic. Yes. There is distal metastasis in the chest or no. So it will give you clue about all the scenario about the question. All the time. Read the first time the question and read the second time, so you will get for clue. Yeah. With which one correct?
Okay. E. Not E or
C.
B better.
The time I want to include the examination under anesthesia, most important. You will see anyone with examination under anesthesia, MRI, pelvis, CT, CT, abdomen, C is most appropriate.
C.
Yeah, C.
C, doctor?
C. Yeah, C, Dr. Simon, yes, C. Because I will examine under anesthesia, I will do MRI by
MRI,
tension, cancer, and I need to see the abdomen, what happens there, and if there is the metastasis in the chest or no. CT all the time for metastasis. Okay? Yeah.
CT for what you said, doctor? Can you repeat again?
Metastasis. If I want the metastasis in the pelvis or abdomen, I will do CT. Yeah, okay.
So what about MRI? What about MRI?
If you have something
for metastasis, MRI
or me. Any tumor not inconclusive,
extension of the tumor.
Yeah. Also invasion by MRI, yes, Dr. Ayman, yes, correct. But usually in the cancer, for metastasis in the pelvis, in the abdomen, in the chest, you will add the CT. CT will be more accurate. Okay? Yeah.
Yes, a 41-year-old gravida is referred by her community midwife to the consultant antenatal clinic at 36 weeks of gestation to discuss about the induction. After discussing the pros and cons of induction of labor, the increased risk of stillbirth because of her age, and therefore the offering of induction of labor around term, the woman inquires about the risk of stillbirth at term, 39 to 40 weeks of gestation.
Yeah, remember here, there is the patient, if she is elder, I will induce early, right? I will not leave the patient. Usually they induce the patient if she is low risk at 40 plus 6 before 41 week. But if the patient here elder, primary and elder, this is the risk for this patient. So they are afraid from the stillbirth before the time.
2 in 1,000.
So you won't induce this patient here. They induce. We had, if we have normal at term, patient normal, our benchmark it is 1 in 200, right? But this patient risk more risk. What I will say. Many times we had confusion about this question. You remember? Sometimes we'll say 1 in 200, it will be no. Let us see what is the option. Yeah. The benchmark is
1 or in 200.
But here
2 in
1,000.
Yeah, and
yeah, what?
2 in 1,000.
2 in 1,000.
C.
2 in
Yes.
1,000.
2 in 1,000. 2 in 1,000. Remember this one. If they tell you
3 in
the
1,000.
normal
1,000.
benchmark in UK, it is
Okay.
1 in 200. But this patient, it is 2 in
Uh-huh.
1,000. Yeah, correct. 2 in 1,000.
3 in
2
1,000
in
is for
1,000.
42 years old.
Yeah.
What?
Remember,
What?
don't
What
jump
did you
to when
say, doctor?
if the patient she had risk, it will be like this. Yeah, reach this point.
Okay.
Note, the answer is D, that is 2 in 1,000.
Read.
Note that the woman
Yeah.
age under 35 years.
Yeah, read.
This
You need to
figure is
read
1
this
in
part.
1,000. Woman,
For the
I'm reading. Woman age more than 40 and or more have similar risk of stillbirth at 39 weeks of gestation to the woman in their mid-20s at 41 weeks of gestation. Hence, there is an argument of offering induction of labor at 39 to 40 weeks of gestation to the woman more than 40 or equal to 40 years of age.
there
So
is
2 in 1,000.
argument about this one. Usually, if the patient she is elder and she is primary afraid about her risk, they will induce early. If we had the normal benchmark of UK, it will be 1 in 200. But remember this point in the exam. This question came many times in exam, and I think all the time we are running and answer 1 in 200, right?
Yes.
The easiest
Yeah,
option.
and we will do mistake again and again, inshallah. But this time, no, we will clear before we go, inshallah.
A 32-year-old primary with no antenatal risk factor attend the antenatal clinic for discussion of management of prolonged pregnancy. She is at 42 weeks of gestation and had a membrane sweep 2 days ago. You have discussed the risks associated with prolonged pregnancy and placental insufficiency, and she has declined induction of labor. So you will do twice weekly CT.
You remember,
and,
all the time I am remembering Dr. Pervin and other doctor, our discussion in the group. I remember when Dr. she posted this question in the group, and we answer the correct. They insist no, because the patient, I think in the question in the group it is mentioned 41 week. They tell no, nothing to be done. See the option here, the patient 42 week and she decline. Her autonomy to decline. Whatever she doesn't want, will her wishes. Will do her issues, this autonomy. But 42 week, what you will advise the patient? Because the risk
twice
is still
weekly
there.
CTG and
Twice weekly CTG and the ultrasound.
Which one? Which
for
option?
the amniotic.
Yeah, which option?
which
Is
one?
the answer okay?
If they give only also 41
What
week,
is it?
because usually I as a
Doctor E. Option E.
Yeah. I will advise her. If she refuses, it is okay. But this is my advice. You come twice weekly for fetal CTG and ultrasound and to determine amniotic fluid. This one, it is the most important. But if she refuses, she can refuse. But I will not leave the patient. I will counsel the patient about the risk and have to follow up like this. Till she will go into labor. Yeah, it is E, correct.
You don't leave her.
You
don't
will
leave her.
You will counsel. If she refuses,
Yeah.
it is okay. You will accept her wishes. Yeah. Correct.
E.
Yeah.
A 30-year-old woman with BMI 45 present in her first trimester with the new nausea and mild impairment of peripheral field. Say BMI 45.
Yeah.
In her first trimester with constant throbbing associated with nausea.
Yeah.
On
Your
examination,
voice,
there is
Dr.
papilloma
your
and mild
voice. Yeah.
impairment of peripheral field.
Your voice, Dr. Vervin, I cannot hear you well. What is
Sorry?
the problem? Your voice?
A 30-year-old woman with BMI of 45 present in her first trimester with new onset constant throbbing headache associated with nausea and vomiting. On examination, there is papilloma and mild impairment of peripheral field.
Yeah.
Uh,
If you
can
will
I see the
make
option,
mistake for this question, I will not help you. This one we discussed yesterday, very fresh. Yeah. And you will tell me the treatment. Yes. Yesterday I discussed this one in the headache.
What?
Consiopathic.
Likely diagnosis, idiopathic
A.
intracranial hyper.
The
Yes,
diagnosis
A.
is A.
And treatment is acetazolamide 500 milligram BD.
Yes, correct. Because we will go back to the question. I will tell you the point. We will begin the question. Because this all the time problem for us in the exam. Remember, the patient, she is in bearing age. She is 30 years old. And she is obese, the second point. Her BMI 45. And other thing in the first trimester. This they give you all the picture and throbbing. Only the papilloedema.
Doctor, her age is a risk factor. She's only 30 years old.
Yeah, risk factor because it will be in young,
BMI.
دكتورة صيمة. The idiopathic intracranial in young patients bearing age. So it is
Okay.
yeah, it is
Uh-huh,
coming
okay.
with the scenario of this one. And the BMI it is
Okay.
45 also. This is the time of and first trimester. Usually it comes in the and the nature of the
Okay.
throbbing. All we had papilloedema, the other one, and the patient she might end by optic atrophy because the pressure. So you will tell the patient she will come regular follow-up because she had papilloedema also. The treatment, it will be by acetazolamide, 500 BID, and the diagnosis by lumbar puncture. And also the lumbar puncture treatment. You will release the pressure.
Dr. Husnia,
Yeah.
hello. I have read somewhere that acetazolamide is contraindicated in first trimester.
No,
I mean, it should be avoided.
No, she can receive. If you receive the guidelines, the headache TOG 2014, the first option acetazolamide. They are not tell no. They tell you give the patient acetazolamide because usually this condition it is coming first trimester, and they advise the treatment by lumbar puncture and acetazolamide. You can give. If you can reach the TOG, it is there mentioned. 500 twice. Yeah, twice.
Okay, thank you, Dr.
It's mentioned in the.
Yeah,
I will show you.
acetazolamide is class C. It's not teratogen.
Yeah,
class
because
C.
this big problem to the patient. If you will leave the patient, maybe she will be blind, optic atrophy. So you will do lumbar puncture and you will treat the patient. Class C is acceptable in this condition. Yeah? Yeah. We need to be sure from the headache because headache all the time. 4 EMQ in the exam. Yeah.
They like headache.
Yes, headache very important. 4 question, remember. And all the EMQ. Yeah. Let us go.
A 35-year-old woman, para 1 plus 4, had normal delivery 17 days ago. She presented to A&E with sudden onset of severe headache, which started 2 hours ago. She had a seizure an hour ago and now has hemiparesis. Her level of consciousness is slightly impaired. Background history includes 4 early miscarriage and family history of deep vein thrombosis in her mother. Her BMI is 44. An urgent CT scan showed multiple collateral veins with an empty delta sign. The thrombosis,
They give you the typical picture here. The patient she had with history of thrombosis. And you see her BMI, mashallah, 44. And you see the picture of the head, severe headache. Usually severe headache, it will be subarachnoid hemorrhage or CVT. And the patient otherwise had normal delivery. Postpartum also. Postpartum.
Doctor, you say about her BMI, mashallah. This is not mashallah, wallah. Doctor.
BMI, mashallah, 44.
You say mashallah, BMI.
Yeah, very beautiful. Very obese, Dr. Saib. Another thing was delivery. Remember CVT? CVT is the third trimester and postpartum, the most time CVT. You see, they give you whole scenario. You need about the headache, inshallah, we'll finish one by one. So it will be very clear for us. Yeah.
And yes, doctor. And the background history includes 4 miscarriage. Means she has some thrombosis.
Yes.
What is the most likely diagnosis?
Yes.
Cerebral venous thrombosis.
Yeah.
Yeah.
Yes. What is the treatment for CVT? For how long, Dr. Perveen?
For how long?
Yeah.
6 weeks?
CVT. For how long?
6 months. 6 months.
Yeah, 6 months, correct.
Low molecular weight.
For low molecular weight heparin for
Okay.
6 months. Pulmonary embolism for 3
6
months.
months, very
Very
long
high risk,
time. Yeah.
very long because very severe patient will afraid any time. You give high long time.
Okay.
This one. Yeah.
A 30-year-old woman attends the antenatal assessment unit at 18 weeks of gestation with few days history of flu-like symptoms. She reveals she has returned to UK last week from 2 weeks trip of Brazil.
Yeah. Brazil, طوال, it will come to your mind. Yeah.
What is the most appropriate next step in her management? Advised to take plenty of rest, plenty of drink adequate fluid and manage pain and fever with regular paracetamol. Arrange a baseline fetal ultrasound with consideration of repeat fetal ultrasound scan every 4 weeks throughout the pregnancy. Counsel the woman about Zika virus and its potential implication on pregnancy and reassure her. Then serum EDTA plasma and urine sample to rare and imported pathogen laboratory for Zika PCR testing only. Should be tested for Zika virus infection and other travel associated infection by submitting appropriate sample to RIPL. E. Answer is E. Should be tested.
E better.
More suitable because she came from
Yes, more suitable.
associated infection.
It's not perfect, but it's more suitable.
Yeah, it is more suitable
compared to other answers. Yeah.
طيب, what about seroconversion about Zika virus? Because also we had argument about Zika virus seroconversion. 2 week or 4 week?
Seroconversion, I say 4 weeks, doctor.
Yeah.
4 weeks.
Yes, we discussed this before and it is 4 week. Because usually if the patient she came back from area like this, I will check after 2 weeks. And after 2 weeks, another 2 weeks, confirm she has the infection. After 2 weeks, I will see still positive or no. So remember, Zika virus seroconversion 4 weeks. Okay? Let's also recall question and we had every day we had review about
Yes. We have review is 2 weeks or 4 weeks. It's coming question.
Yes.
A 35-year-old woman in her third pregnancy come in for routine prenatal visit at 18 weeks of gestation. She has 2 children aged 3 and 5. She is a school teacher and is concerned about the risk of slap-cheek disease as she has been exposed to the child with a rash. The diagnosis of human papilloma virus B19 has been recently confirmed in the school. However, she is asymptomatic.
She is exposure only. She had exposure. She is not symptomatic. So what you will do? Certify it and she had slap-cheek parvovirus. طيب, we will think about what if she is still not.
Next step, amniocentesis for diagnosis of parvovirus B19, maternal antibody for parvovirus B19, maternal mid-fetal measurement, also her, and no further testing, umbilical blood sampling.
Yeah,
we will see maternal antibody parvovirus B19.
What you will do?
Maternal antibodies.
Yes, maternal antibody. Yes, I will check. Yeah, I will check the immunity first. After that, I will decide according to her test. Yes, because she exposure only to this one. Yeah, correct. Yeah.
A GP calls you for advice about the 25-week woman who is 14 weeks pregnant, who has presented with one-day history of rash consistent of the red spot behind her ears, across the head, neck, trunk, and leg. She also complained of painful swelling behind the ear. She is noted to have a temperature of 38 degrees centigrade. The GP is considering a possible diagnosis of primary rubella infection.
Yeah, the typical scenario of Ebola. You remember behind the ear and the arch and all the typical.
Behind the ears.
Yeah, behind the ear. All the time, remember the rubella. We'll see the option what they want. Because I think before they are asking about rubella, but now they ask what? Yeah.
They like more chicken pox. They like more chicken pox.
Yeah, chicken pox and herpes. We'll revise this book.
And herpes, yeah.
Most important also.
Herpes and chicken pox.
Yeah, the infection. Yes.
Which of the the risk to the fetus of primary rubella infection is most appropriate in this case? Which of the following statement about the risk to the fetus in this case of primary rubella infection is most appropriate in this case? The risk to the fetus of primary infection after 20 weeks is substantial. The risk to the fetus of primary infection between 16 to 20 weeks is substantial. The risk to the fetus of primary infection in the first 16 weeks carries a minimal risk of deafness only. The risk to the fetus of primary infection in first 16 weeks carries no documented risk. E. The risk in primary infection first 16 weeks is substantial. Answer is E. The risk to the fetus of primary infection in first 16 weeks is substantial.
Yeah, but remember, we had a recall. Remember ourselves by all recall. As a recall, the patient 8 weeks, and she came. What you will ask the patient about?
Termination.
Yeah, termination.
Termination.
It came twice. This one it came to 19, and it came last exam also. Yeah, first 90%. Yes. Yeah, the termination. Yes. Came twice. It will come third time this time. we are waiting, expecting. Okay.
A lady suffering from endometrial carcinoma who undergoes a hysterectomy as a part of her treatment. She was unhappy about the care she received on the ward following the procedure and has mentioned this to you a few times on your daily ward round.
What you will advise the patient? If she's complained many times, she's not happy. She's not happy about the care they given to her after her operation. طيب, what we will do when we have other option, you will tell me. Yeah. Clinical governance.
Yeah, what would you do in this situation? Encourage positive thought in lady by discussing better aspect of the care. B. Encourage the lady to put and complain. C. Fill an incident form regarding the above. D. Provide a detail of patient advice and license service. PAL. E. Ensure the lady that you will talk to her. You will talk to the staff involved. D. PAL. Provide detail of patient advice and service.
If the patient is unhappy, this care it will be in the same hospital there. You will advise the patient to go there and ask. They will explain to her all things. Like for us, this one, social worker, right, in our hospital. Okay. If the patient complain, I will ask her to go there. There, they have this balls to go there. But if the patient also about this balls, she is not happy. Where is the patient she will go? What your advice after this one? She go there and they explain her about everything. What she will go after this one?
She will, if they did not resolve at that local center.
Yeah.
Go to ombudsman.
Yeah,
services.
Ombudsman. Yes, she will go there.
What?
What, doctor? Ombudsman Saima, this care outside the hospital. This balls in the hospital. Like
I never hear, doctor.
Yeah. This one.
What is the name?
Ombudsman. This one, the care outside the hospital. If she is
Can you type one of you, dear? Type in the message.
Yeah.
I will type.
I will send for you, Saima, at the end the note about balls.
Okay.
And this one. But remember me today I send for you.
Okay.
Don't forget.
Thank
you. Yeah, I will write. I will send for you. I can't notice one. Ombudsman. Yeah, if she's not happy about the hospital, this also other station outside the hospital. She will go there and tell her problem there. Yeah. Okay.
Which aspect of clinical governance is characterized by the following definition? A quality improvement process that seek to improve patient care and outcome through systemic review of care against the explicit criteria and the implementation of change. This is clinical audit.
Clinical audit, yeah, correct. Clinical audit. Tell me, Dr. Bervin, the stage of the audit. How many cycle of audit? Tell me, so you remember, I shall not forget.
Five.
Yalla, tell me the 5. Yes.
First, we will identify the data.
Yeah.
Then we will collect the standard of data. Then we will compare the data with the standard, and then we will implement the change, and then again re-audit.
Re-audit, yeah. This clinical audit very important. So we had 5 cycles, inshallah, not forget it. Yeah. Good.
Ma'am, please show the question again. I could not see that. The previous one.
You want the previous? Yeah, to improve the patient care and output through the systemic review of care, accessibility criteria, and implementation of the change. This is the step of the you'll take other involvement like in your trust or your hospital. After that, you will discuss, they will accept for you can do. After that, you compare by the standard. After that, you make your point, and then you implement and re-audit. This is the cycle of audit, 5 cycle. Okay? Yeah, let us go.
Yes, ma'am.
You would like to conduct a test to see if there is a statistical difference between the birth date on Monday and Friday. Which test will
Tell me about the test, Dr. Bervin. Remember the blue chart where we are. First, tell me by step. After that, you answer. How I will choose the test?
Test.
Sorry, doctor, I don't know about. I'm very.
Anyone?
I don't know anything about it.
Where we are, so which test we can choose? We had Ferris one. I will remember you. I will say. But I want any doctor to complete. If we had Ferris, we had correlation in this side. 2 variables. This increase and this decrease. Positive correlation, negative correlation. In the middle, we had numerical. In the other side, we had categorical. Alas, now we are numerical. It is not correlation. It is numerical or categorical. Anyone to explain?
Numerical.
طيب, numerical. Tell me, Saima, continue. About numerical, we had 2 groups and more than 2 groups. Now we had 2 groups.
You are the best.
Go
You
back to the question.
continue.
Yeah, go to the question. You had 1 group or 2 group or 3 group? Because if you had 3, it will be the other side, ANOVA. Now we are in the 2 groups.
There's 2 groups.
Related or not related?
2 groups.
Yeah, we are 2 group, numerical data. We are 2 group, related or not related, parametric or not parametric. Birth weight is parametric or not parametric. Yeah, baby born Monday, Friday. It is different. Monday, Friday. Yeah, you will compare between them. The test. Monday, Friday.
So,
different. صح? That is not related. Parametric. Which test you will choose? Not numerical data. It is 2 group. Not related.
Not related.
unpaid test.
Yeah.
Unpaid test.
Remember, it is numerical data. We had 2 group, parametric and not related. So umpire t-test. This is our friend. Umpire t-test, umpire test in every exam. Remember, in the middle of the chart. Middle of the chart. صح? We had left, we had right, we had middle. Now in the middle. The middle also in the left. Numerical data Not related, parametric. Umpire test. You remember which one I tell you? No, no, no. Man-Whitney test. Not related. Non-parametric. Man-Whitney test.
No, no, no,
Yeah,
man-Whitney
no,
test.
no,
And
no.
how did we decide that this is parametric?
Hello?
Ma'am, I'm saying, how are we deciding that this is parametric?
I tell you the parametric many times had this one cannot understand. But usually they are telling parametric test. If you remember in the session, I give you two tables. If you want to save this one, so you will not be confused. Other thing, if you have the test, this test normal distribution. If they tell you is normal distributed, you remember the bell shape, not skew to left, not skew to the right, and the mid mode and this one in the middle, same, the one line. This is the parametric test. But usually any question they are not telling this parametric number. From the scenario, from the question, you will get it. Sometimes, many times, if they are not tell me, no, because if not parametric, they will tell you not normally distributed. So it will be non-parametric test. If they will not tell you anything,
So,
put
ma'am,
the scenario, the question again,
so
and
Dr.
decide. Yeah,
So, Dr. Husnia, we assume that it is parametric if it is not mentioned.
yeah, it is like this. But usually they will, you can understand from the scenario of the question. You can understand where are you. Remember this chart.
Okay.
Put this chart in front of you till you will go to exam. You will remember. Correlation this
Yes,
side,
ma'am. That chart.
yeah, numerical this
That
side,
chart is clear.
categorical this side. You remember the blue chart in the session? This
Yes,
one will
ma'am.
help you
Yes,
in all
ma'am.
the
Yes.
tests. If you cannot understand
Yes,
this
that
one,
chart
at
is
the end
very
of the
clear.
session, you revise again. Remember me, I will revise this again before
Yes,
you
yes,
finish.
that chart is very clear and it's very good.
Yeah, very nice this one. Any test you can choose about this one. Also, at the end of the session, remember me with the discussion again. Today we will not close the discussion till you will understand anything, inshallah. Don't worry.
Can you share that chart again, please?
Yeah, I will send and I will explain at the end of the session, inshallah. Okay? Yeah, go.
Thank you.
Yalla, go.
Thank you.
You are interested in finding out which type of anesthetic is more comfortable for the patient perspective for use during cesarean section, epidural or spinal. Which type of study would you think in this most appropriate to help you to answer your question more effectively?
Yeah,
This is RTC, doctor. This I know. Medicine.
Yes, we finish the test. They are here about the study. Yeah, we finish the test. Remember me the study. Anyone to tell about the study? Any note, short note, so we can remember. Study. Dua, can you tell me about the study? Short note, no problem. How you know this is a randomized control trial?
Study.
Yeah.
RCT.
RCT, why? Why RCT? Remember, we will when we revise this one study, we had experimental and not experimental. We had two groups, right? There is experimental and the second one not experimental. In the experimental, we only had this randomized control trial. Usually, the other one no treatment. All the cross-sectional or retrospective or cohort, we had no treatment. This is the only we had treatment. Usually, you will compare by two. You see here, epidural, spinal, this one you will give treatment and you will observe. And this is the strongest evidence in the casualty. And this is the green type, green guideline depending on this one. Remember, this is very easy. If you had treatment, they tell you nifedipine, albumet, any treatment all the time. Remember the RCT. Okay?
So, Dr. Husnia,
Yeah.
what about that case control study?
So, case control.
What is the definition of case control?
Case control, not treatment. And usually the case control is retrospective study, not prospective study.
Okay.
You will go back
Retrospective
and you will see. And you will discover from this a rare disease. Because you will go back and take the history and there is bias here because not correct. because sometimes they will not give you the accurate history to see, not like cohort. Cohort more better
Okay.
than case control. From the history, to get respective.
Yes, because it's a more
Yeah.
broad spectrum. It's a more larger study.
You will ask, see this group and see this group and compare which one it affected, which one not affected. So there is bias in the study. So a case control all the time retrospective, but cohort can be retrospective and can be prospective. But usually cohort prospective.
Prospective.
Yeah.
Okay, cohort usually prospective.
I think there is a background. I think if you close the mute all, it will be better for the recording. Many background. Mute all yourself, doctor, so it will be clear.
A 70-year-old woman present with 3.5 into 4.5 trace irregular fungating mass on the left labia extending to the clitoris. A representative biopsy of this lesion has confirmed moderately differentiated squamous cell carcinoma of the vulva with a depth of invasion of 8 millimeters. What is the most optimal management plan for this woman?
Yeah. All the time, remember the vulvas treatment. You see, if you can do the surgery, it is better. Alas, and all the time, Dr. Bervir, remember the lymph node. If you had, I will remember you the rule of 2 and 4. If it is near to the midline by 2 centimeters, this one. And the other one, if the size of the tumor less than 4. Far from the midline, 2. And the size of the tumor more than 4. This one I will do the lymph node, it will be ipsilateral, because the other side it will not be cross. But if near to the midline, less than 2 centimeters, or the size of the tumor is big, so I will do bilateral lymphadenectomy. This patient, see what? I will do?
It's all 8 millimeters.
Yeah, I will give you the option.
Options: radical right excision only, radical right local excision and left groin sentinel node biopsy, radical right local excision and left groin lymphadenectomy, radical right local excision and bilateral groin sentinel node biopsy, radical right local excision and bilateral groin lymphadenectomy.
Where is the mass? Where is the mass? If cross the midline, if in the midline, you see the fungated mass in the left labia. Remember all the time labia. It will be crossing, it will not be ipsilateral. And it is extended to the clitoris. Where is the clitoris? In the midline. So it will be bilateral lymphadenectomy. And this mass is big.
Okay.
Yeah. Clitoris and the labia. If they tell you labia, also it will be cross the midline. So it will be bilateral. If they tell you it is far from the midline, more than 2 centimeters, and the size of the tumor less than 4 centimeters, it can be ipsilateral. Here, what you will choose. And you see the woman presented 3.5 centimeters multiplied 4.5 centimeters. Big mass. So it will be, which option? It will E. Radical wide local excision and bilateral lymphadenectomy. Yeah. All the time, remember yourself, rule 2 and 4. If labia, mention labia, remember that it is cross. Because labia, you see, if you remember, and the clitoris also in the midline, so it will be bilateral. But if it is far from the midline, more than 2 centimeters, and the size of the tumor less than 4 centimeters, I can think by lymphadenectomy it can be ipsilateral. Because the risk of the ipsilateral, this one, it will be only 1%. So I can do IPSI. Yeah.
A 75-year-old woman is seen in Urovalley clinic complaining of pelvic organ prolapse. Of note, there is a history of intermittent steroid cream used for a sore and itchy vulva. On examination, there is a warty lesion on the vulva that is 1 into 1 centimeters of the left inferior aspect of labia majora.
This is the option.
Yeah. What would be the most appropriate action? Arrange excision biopsy of the entire lesion under local anesthesia. Prescribe topical imiquimod on the lesion. Reassure the woman that the vulvar condyloma are common in postmenopausal women and concentrate on the reason for the referral, the pelvic organ prolapse. Refer to the dedicated gynecological oncology vulvar clinic for opinion. Try the course of topical steroid to review the lesion in 6 months.
Yeah, patient risk, what you will do? You will treat the patient or you will refer the patient?
Can I see the question, doctor? I forgot the question only now.
Okay. Yeah.
75-year-old woman is seen in urogynecology.
Yeah, in the urogyne. Where is the patient now? Urogyne. This is not their specialty. This urogyne not their specialty. The patient she need doctor onco and vulva because they are subspecialty. Yeah. So it will be referred, doctor. Yeah.
Okay.
Because they are not the one to treat this patient. Need the specialty. Yeah.
So D, refer to the dedicated gynecology vulvar clinic for the
clinic for
the opinion.
After that they will decide. Yeah. Okay.
A 25-year-old Asian primary present for her booking appointment. Her sister had a baby that was small and was admitted into special care for 4 weeks. She is worried about the baby being small too and requests a serial growth scan from 28 weeks of gestation.
Where we are, which guideline now? Her baby, yeah, is small and was admitted small of gestational age. Remember the chart of small of gestational age, Dr. Bervin, and tell me, where is the patient? She will come from what? Because 25 year, primate will be low risk patient. She will follow by midwife, and the midwife she will do the customize this one. And if she feel regular, everything is good, okay. If the patient she had the midwife, she had concern about this customized, it is low for, she will refer to you. When she will come to you, first you will do ultrasound. You confirm. The patient is small for gestational age, she will be with you in the chart of small for gestational age, or the patient she is okay. See here, what is the history here? The patient is normal, I can send her for regular care, or the patient is small for gestational age, she will be with me in the chart of small of gestational age. I will give you the option.
She is worried about her baby being.
Yeah, you want to read it?
What is the most appropriate?
Yeah, she had any risk, the patient here? She had minor risk, or she had a major risk here, or no?
She has no risk.
She has no risk.
No risk, 25 years old, we had no risk here. Okay, and if she had, think first I will do for her ultrasound. Ultrasound confirm small for, because this question all the time confusing for us. Ultrasound confirm baby less than 10 centile. After that, the patient is small for gestational age. So I will follow by estimated fetal weight, abdominal circumference, and Doppler. But here, the patient, I will determine the risk. If she had 3 risk, minor, or she had 1 minor. Where is she now? Yeah.
What is the most appropriate?
Yeah. There is the option, Dr. Bervin. After that, we'll choose. Yeah.
Monthly growth scan and like a ultrasound scan from 28 weeks of gestation. B, refer for ultrasound scan after single symphysis fundal height measurement below 10 centile or serial measurement that would suggest a slow or static growth. C, the use of population-based chart rather than a customized growth chart. Transfer back to the midwife-led care. Weekly fundal height measurement by community midwife. Use of population.
The patient risk, Dictora, she had minor risk or major risk, or no?
No, she don't have risk factor.
She had no risk. طيب, what you will do if the patient she had no risk? You will do ultrasound first, no risk. will advise the patient when she will do it. Regular follow-up, صح? Serial ultrasound only.
B.
Yeah, B. Referral for ultrasound.
Midwifery.
Single, below the 10 centile or serial measurement that would suggest slow static growth. After that, like patient like this, I will tell her to come like serial, 2 to 4 week follow-up. Yeah, but I will not, the patient is still not small for extension, not confirmed. Remember all the time, if confirmed, it will be with means this one, the chart for follow-up with small gestational age. If the patient knows, she will be in serial ultrasound.
So what is the answer?
Ultrasound.
B.
Yes. Refer for ultrasound scan.
Yeah, first one. Remember, recall and all the time we had mistakes. This one, you think the patient is small for extension.
Yes, always they.
Yeah, we'll do no. First you will confirm. You will remember it is with you in this chart or it is out this chart. If out, it will be serial ultrasound scan, and she will measure 2 to 4 weeks. Yeah.
Mr. A suffered from severe dementia and develops pneumonia, which worsened to the extent that she was now requiring ventilation. Her respiratory function deteriorated despite ventilation.
What is those answers?
A decision need to
be 1 minute there, Dr. Bervin is asking about the answer. Okay. Yeah.
Hello.
Serial ultrasound. Yeah. Yes. Yes. Anyone asking?
Can you hear me?
Yes, yes.
Yes. I'm sorry, earlier my mic was not working.
Okay. It's okay.
Because you asked me to answer one question. I'm sorry. Okay.
No, it is okay. It is okay, Victor. Okay. Yeah, Dr. Bervin, continue. Yeah.
He suffered from severe dementia and develops pneumonia, which worsened to the extent that she now requires ventilation. Her respiratory function deteriorated despite of ventilation. A decision need to be made regarding the continuation of ventilation.
She has dementia now. Dementia. Who will decide for her to discontinue this ventilation? I will give you the option. I will choose patient dementia, and they want this a big problem. They want to discontinue the ventilation. Who will decide for the patient?
Who is able to make the final decision? An advance directive from Ms. X before the onset of dementia, which does not specifically mention mechanical ventilation. B. Her consultant using best interest principle. C. Her daughter, to whom Ms. A has given confidence that she did not want to suffer if placed in such a situation. D. Her son, who is having lasting power of attorney. Her husband. Her consultant using best interest principle.
Yeah, but yes, correct. No son, no daughter, no husband. Alas, they cannot decide for her. But I remember this A.
But if the son has power of attorney,
yeah,
has power of attorney, so he can take the decision.
Yeah, he's having lasting power of attorney. Why we don't take this one?
Her son who has lasting power.
That we can't take in life-saving decisions. Life-saving decisions should be taken by the consultant.
Yeah, this consultant. But if she had
the power of
attorney is more important, ma'am, because the consultant cannot decide by himself or herself.
The consultant.
Yes, this is best interest.
Yeah, best interest it can be, but see the first one A, an advanced directive form before the onset of dementia, which does not specifically. The problem is specifically, but if she had advanced directive and witness and sign, and when the patient she is okay before the dementia, and very specific it can be, but the problem here does not specifically mention. If she tell, if I will lie, I have problem like this, do this one, and this is a witness and sign, it can be, but here not specific, so it will not be the correct answer.
Yes, ma'am. So after advance directive, the second thing should be seen as the power of attorney. the person who is having the power of attorney, if she has made someone, then that person can take decision for her for the life-threatening condition.
This critical
or whatever decision regarding the treatment. If advanced directive is not
yeah,
it is not specific, so we cannot choose advanced directive here. So second step is the power of attorney.
Risk. It will be by the consultant. Her consultant, he will decide, not the other, not her son, because sometimes
no, but the consultant
for something like for this he cannot decide to the patient because he is tired of this dementia. His mother, she is very dementia. He is tired. He want to finish this one. Her daughter also, maybe she is tired about taking care. But the consultant no. Advanced directive technique, if this one be very specific, it can be. The other no.
Dr. Husnia, what does exactly power of attorney includes? I mean, it includes the health-related issues of the patient also, or any other thing?
Yeah, includes something related to the patient, but not something like discontinue for the ventilation. It cannot be, because here there are other risk factors: the patient, the daughter, the husband. Maybe they are tired about the patient, but her advanced directive.
So power then, so ma'am, then power of attorney is not a specific thing. So it is also non-specific.
Yes, but this, if the advanced directive technique, it is specific and sign, and when the patient she is well and fine and witness, it can be this one. The second one is her consultant.
So that should be the first option if it is specifically given.
If it's specific, this is a better option. If she had no specific, it will not be. And witness and sign and the patient before dementia, when she is okay, she's fine.
Victoria.
Yeah. No.
1 minute, I didn't get the question. The question is asking the patient, the consultant is planning to take to stop the ventilation.
Can you please again explain what all is included in power of attorney?
Power of attorney. This one in Arabic.
He went to the court and he has something to.
When I will be sick, power of attorney like this. If the patient she tell when I will be sick, if I will be like this, my daughter by name, she tell my name, she will do this one and this one, and he will go to the court and it will be witness and sign. She tell like this. If she had any problem, she is like tell when I will be sick, no one he will take care about me except my daughter, and she mentioned by name, and this written and signed by the court. If she had any problem that time, it will be it is the one. The advanced directive, this one, she will write by herself. If this something happen for me, like this, it will be very specific and witness and sign. So they can be done. The like major problems, the patient dementia, and they put the patient in a long time in the mechanical ventilation, and all the family, they are tired, they want to stop the ventilation. This big decision, who will take this decision? And the patient now dementia, and she is under ventilator.
Victoria, can I see the question again, please?
Yeah.
Okay, thank you, Doctor.
We have very difficult decisions, this one. But if the patient, she write very specific, if this will happen.
So, doctor, shall I tell one thing?
Yeah.
So the lasting power of attorney, they can decide on the patient's treatment, but not on life-saving decisions like ventilator or.
Yeah.
They don't have right to decide.
They can. This power of attorney can be like other thing, like this one who will take my money,
other treatment,
he will take care about me when I will be sick. Like this, it mentioned by name and witness and sign. It can be was this big decision because maybe it affected by other issue. Maybe the daughter she's tired, she want to not to take care about her mother coming and going. But if the patient, when she is well and fine, and she decides this, she write her directive technique and it's very specific like stop the ventilation, very specific. It can be, but very if not specific. This one, it will be the consultant. Best interest, he's the one to decide.
Option.
Yeah.
Then best interest.
A 12-year-old girl who lives in care house attend a sexual health clinic requesting contraception. After taking a thorough sexual history, you discover that her partner is 16 years old and she does not feel that they are doing anything wrong. She has asked you not to share her information with your safeguarding because she is afraid of getting her partner into trouble.
Yeah. Remember, Victor, the age, they are telling the 4 years different. This is it will be some problem. Because if the same age, less than 4 years, it is okay. But you see also the age, 12 years, very young. But about, I'll give you the option after that. It explains. Yeah.
Should you do? Agree with her request confidentially and issue the contraceptive? Agree with her request confidentially but refuse to give her any contraceptive as she is under the age of consent for intercourse. Inform the police immediately. Issue a contraceptive and safeguarding.
Doctor, can you mute yourself? Can you mute all? Very background. Can you mute all? Yeah.
Not the issue of contraceptive, but involve the safeguarding team. Doctor, we cannot give her contraception, no, because she's only 12 years.
No, the contraceptive you will give Dr. Bervin, because the risk of to get pregnant in this age, the risk of all you can give this one contraceptive. You remember the Fraser guideline, the contraceptive you can give, but you will this one because you see her age and the different by her age and this one 12 and very the 4 years or more and the patient very young. You can give her the contraception, but you will make you will save this patient very young. But contraceptive you will give anyway you will give. Yeah.
Show the question again, please. 1 second. Question, please. Okay. Thank you,
Her partner is 16 years and she's 12 years. Her age very young and the partner more elder than her. There is a gap. They are telling 4 years or more, it is a problem to the patient. But contraceptive, because if you will give, if you will not give, she will do whatever she wants. So you will cover the patient. She will not get pregnant in this age. Contraceptive you will give, but you will save the patient also by other. I will give you the option, Dr. Bervin.
Doctor, below 13 years old, this is illegal.
Yeah, illegal, but what
is
if you will not ask her to do this one, she will do. You will cover her this one about contraceptive, but you will see other people, they will, this safeguarding team, I think the option D, it will be more issue contraceptive and involve the safeguarding. All the time you give contraception, no problem to give, because you will not follow her.
Not informing the police?
Yeah. Which one? Other for confidential refuse. You will not refuse. Anyway, you will not refuse. Not issue, you will give. Inform the police immediately. No. The safeguarding, they will cover this because she is child. They will cover by safeguarding team. They will follow her, what she is doing. Any problems, they will interfere. But contraceptive, you will give. Yeah.
Okay.
Yeah. You want to read the
Doctor, if there is a 4-year of sorry, if there is a 4-year difference, so it should not be considered as a rape.
No, not rape, because if a rape, it will be no agreement. This girl, she agreed to do the sex with this boy, but the difference, it is big. So it includes the safeguarding with you, and you will issue her the contraception. You will cover her from the get pregnant in this age and complication from this pregnancy in this age. And safeguarding, they will follow the boy and they will follow girl. If there any problems, they will interfere. But it's not rape. Rape, it will be by force. There is agreement between them. But the problem, her age very young.
No, doctor, but a girl less than 30 cannot consent, no? She can't consent for sexual intercourse even if it is mutual.
It is 16 years for sex. She can give consent. Not
Correct. Yeah, but here's the problem
But
with GIFA.
He's under 30.
there is no sex below 13.
No sex, yes, but
Okay.
what you will do here is a case like this. See, children under 17
Yeah, I'm going to give her.
to able to consent.
I'm going to give
And
her.
most of all, be reported to safeguarding team. Also, significant age gap more than 4 years should raise alarm bell for grooming and exploration. It's likely the intercourse will take place even if you advise against so. This is the point I explained to you. If you tell advice against this one, they will do. But you will give her the contraception and you will inform the safeguarding team, it will be with you. This is not legal age for intercourse, for sexual activity, not legal. We are agree, not legal.
Yeah, doctor. Yeah. Of course, it's not legal. But why we don't call the police? I mean, rather than
safeguarding, they will be the solve the problem. Not like police, no. Safeguarding, they will solve the problem and they will observe any of the problems, they will interfere. Because this one is 16 years, doctor. Police what will do? Only he will report and this one. But safeguarding, this is the
because
place
both
to
of
save
them
the
are
children.
children.
But safeguarding, doctor, this is the place. This is the place to save this girl, this children, this child.
Okay.
This child.
Okay.
Yeah.
Thank you.
Yeah.
To evaluate a possible association between maternal smoking and birth of Down syndrome child. Association between maternal
Remember, we are aware. Dr. Vervin is a study. I will show you the option. Yeah. We'll go back to question again. Better to remember yourself.
Survey, questionnaire,
Case control, I think.
To evaluate a possible association between smoking and birth of Down syndrome child.
Remember yourself, doctor, about you had here the study. It will be prospective or you will go back retrospective. Because not cross-sectional. All the time, doctor, I am remembering myself like this. If this need observation long time, it will be cohort, and it will be most of the time prospective. I am thinking this happened, this finish, or I can go back to the history. It will be case control. Something happened now, the cross-sectional. Something I will between treatment, I will comparison. I will give treatment. It will be randomized control trial. So you can get this one to evaluate possible association between maternal smoking and birth of Down syndrome. This he will go retrospective or prospective. If prospective, it will be cohort. If I will go in the back in the history, like patient she delivered Down syndrome, and I will see if one she is smoking, one not smoking, and I will observe. So it will be case control. Which is which?
This one prospective cohort. Cohort.
Why cohort? Because cohort will go prospective, Dr. Bervin. I need something. Down syndrome, I will see this patient, she's taking smoking, not taking smoking, the other one. And I will, it is case control. I will go back in the history and I will see. Yeah. All the time, remember yourself like this. It is prospective or retrospective. Experimental treatment. Cross-sectional now. So you will not forget about this. Yeah. Let us see.
A 35-year-old female, gravida 3 parallel, previous one cesarean section, gestational age 38 weeks, big presentation. Estimated fetal weight is 3.8. This is her second time to come with a complaint of decreased fetal movement. What is next? Deliver.
This is our question. Where is Saima? She left? Yeah. I remember. The patient, she had breast one cesarean. This came.
Doctora, I am here.
Yeah, okay. This
Yeah,
is
I
question.
remember.
Yes,
Yeah, yeah,
your question.
yeah,
We had any
yeah.
question. We have some problem. We argument about the
Yes.
question I put here. The patient previous cesarean section, and she is 38 week. And the second time, remember me in the chart of reduced fetal movement. If the patient she came for the second time with the decreased fetal movement, what I will do?
We are going to make her CTG and refer her for ultrasound, not deliver.
No, usually,
right?
yeah, Dr. Who, Sarah?
Right? You are going to make her CTG. Yes, yes.
Usually, if the patient she comes, we remember ourselves by the chart of reduced fetal movement. If they came the patient for the first time and she's complaining with decreased fetal movement, I will determine the risk. The patient she had risk for this one decreased fetal movement. If she had no history of decreased fetal movement, no risk of the patient. No risk, I will take by Doppler ultrasound. If the patient no risk, I take by Doppler ultrasound. Everything is good. I will reassure. This is the first time to come with decreased fetal movement. I will reassure the patient and I will ask her if she had second decreased fetal movement to come, and she will sit like 2 hours and count this one movement. If more than 10, it is normal, and she will continue her regular care. The other thing, if I check by the patient, I check by Doppler to see no fetal heart rate, I will confirm usually by ultrasound. And as you remember, we tell ultrasound by Doppler 3D. No, by here first in the chart by ultrasound to see confirm intrauterine fetal death. The patient she will go into your protocol. You will leave the patient to go expectant management, or you will induce immediately. You will follow according your protocol. But if the patient she came second time with decreased fetal movement, this patient it is risk. You will do CTG and you will do ultrasound. Any problem, you will deliver the patient. See here in the scenario, all risk, Victoria, we had because she had cesarean section first time, 38 weeks, breech presentation, and baby weight. See the baby weight. Second time to come with complaint and decreased fetal movement. What you will do? I will show you the option.
ECVN deliver at 40 weeks, cesarean section, induction of labor at 41 weeks, reassure and discharge, ECVN induction of labor now.
Cesarean.
Yeah, because we discussed this question before, you remember? If I will do external cephalic at 40 weeks, this is the second time the patient she will come. I cannot leave the patient like this. You will consider if she's second time decreased fetal movement.
I have one question.
Yeah,
if the patient have a cesarean section, can I do her external cephalic version?
Yeah, previous one you can do.
So I can do her
you can do external cephalic version to the patient. But you see here, Doctora, it is when we discuss this question, there is many problem in this scenario, many problem, not only.
And her baby weight is quite large, baby.
3.8. And the patient previous cesarean. And baby breech, and second time decreased fetal movement. They want you, Doctora, to be safe, doctor. Don't be in the dialogue.
Okay.
كله problem.
The same way in the
all problem.
Presentation.
The safe doctor, so they will pass the exam.
Previous.
If safe doctor, they will repeat.
She has a good collection of all problems. Previous cesarean, now is breech, now is large baby.
If I will reassure, if I will reassure external and deliver at 40, second time she comes, maybe at 40 she will come to me with IUFD. No, I cannot do. Reassure and discharge also I will not do. If the second time she came with decreased fetal movement, I will do CT and will do ultrasound. Remember all the time the chart. Most of the exam, maybe 2/3 of exam from the chart or this GTG. Yeah.
Okay. Yeah. Thank you, doctor. Thank you.
I collect all the problem. Any question we had doubt, I put here. Let us see.
That's very good. Yeah.
So we'll clear our concept, inshallah.
Determine whether 4-degree perineal tear increases the incidence of rectocele in future. Determine the incidence of rectocele in future. Option.
Yeah, I will give you the option.
Wilcoxon match pair T test, Fisher exact test, 2 sample T test, Jaquez test, Pearson test.
Yeah, go back to the
Doctor,
question.
this may be the first one. Hey, Wilson.
Yeah. Fisher exact or Wilson? Which test? Remember ourselves. I don't know. I am not happy about this answer of this question. Tell me. What? Go back to the question. Where we are? Determine whether the 4th-degree perineal tear increase the incidence
In
of
this question, we
rectocele in
are
the
going.
future. 4th-degree perineal tear and rectocele. We had no number here, صح? We had
we are
variable. We had any relation.
Yeah.
This increase, this decrease. We had any variable. Because if I will go through the chart, which one it will be? I am really, for me, I'm not happy about the answer. But this one,
Correlation.
yeah, any correlation between the
Victoria,
Whether there is any correlation.
Yeah.
Because they find it one group and follow it in the future, so it's unpaired. It's a paired, I mean. So, like, because of parametric, I think like this: one group, and you are going to follow it now and then.
But it is numerical. If by your test, it will be numerical. Victoria, who? Sarah?
No, it's not numerical.
Yeah, Sarah, who?
No, it's not numerical.
Yeah, not
Yes,
numerical.
this is
It will not be the
yes,
middle.
DR.HUSSNIA.
Yeah. Yes, Sarah. If it is numerical, it will be in the middle. You will choose from this test. Remember, here, this was Fisher exact, and Pearson test. This is the other side, and T test if it is will be numerical. Chi-square if we had two group categorical in the other side, 2 or more. Remember, 2 or more.
Maybe it's E. Pearson test? We don't know what is the
The answer
Pearson.
chi-square. You are agree about this one? Chi-square the answer.
But this is not two different group. How it can be? Yeah.
The answer chi-square.
Oh.
The answer chi-square. I remember you about chi-square. If it is match or no, I don't know. For me, I feel this is not correct answer. The chi-square, you remember we had categorical data. If we had two group, it will be McNemar Fisher exact. If we had two group or more, it will be chi-square. 2 or more. And yes, you remember null hypothesis. So it will be chi-square. Null hypothesis is comparison between two. Null hypothesis what you will comparison between two something, and you will expect it will be equal. This is the null hypothesis. Categorical, this chi-square, it will be two group or more. Here we had two group. I think it will be, but I'm not sure about this one. But this is the correct answer I think I get from Strat.
Okay.
Yeah, for me it is
so
not
it's
clear.
The correct answer.
Yeah, I don't know. But if it is chi-square, we had the test, it will be null hypothesis, and we comparison categorical data, and it can be two group or more. See the option, not numerical. All the other it can exclude. See the option. Two sample T test, no. Fisher exact test, yeah, it is related or not related. If related, it will be Fisher exact or McNemar. Not related, it will be two group or more than two group. It will be chi-square, or if null hypothesis, or two group or more. By exclusion, yes. By exclusion, yes, but by this one, I don't know. Okay. This test all the time is a problem. Yeah. Yeah, let us go. But we are trying our best to understand the test. Yeah.
A woman who had recently had uterine artery embolization performed for the fibroid uterus. 18 week size, intramural and submucous fibroid, present to emergency department with fever, nausea, vomiting, foul smelling vaginal discharge.
What is the problem? She did uterine embolization, right? At a big fibroid, and she came with this symptom of nausea, vomiting, foul smell, sepsis after uterine artery embolization. So what you will do?
This is complication of the which investigation is suited to guide management. CT scan of abdomen and pelvis, hysteroscopy, MRI of abdomen and pelvis, trans-abdominal ultrasound, transvaginal ultrasound. Doctor, we will go for
which
to
one?
see if there is any transvaginal.
No, remember when you will go for uterine embolization, the most important thing you will do before and after. You will do MRI before and after. Why before and after? First, you are mapping, so you can do this one good. You will see where you will go, and after you will do. It is must. You will do MRI before and after. They are mentioned before and after. After, if you had any problem, anything inside the uterus, it will not be infection later. And if she came, also you want to do MRI before and after. Remember, uterine artery embolization, MRI before and after. First for mapping. Second, to detect any problem. Okay? Very clear mention. MRI before and after. Yeah.
Can you take the question slide, please? Question slide. Yeah.
Because sometime after uterine embolization, maybe there is some part of this fibroid that will be intrauterine, and it will keep there. After that, patient will come with this one, sepsis will be inside. So usually better you will do before and after MRI. Okay.
Yes.
Yeah. Remember MRI before and after.
Yes. Now.
Yeah. I will show you first. Better you read.
Is that okay to identify a partially
Yeah.
differentiate?
They will come with infections, they will come with ovarian failure, they will come with all their, and this percentage, inshallah, we remember the percentage. Yeah, okay.
A 36-year-old primary woman present at 36 weeks of gestation with low-grade fever, chest pain, and cough. Her observations are stable and she's able and appears comfortable at rest. You suspect pulmonary embolism. When counseling the woman about the investigation, which of the following should you inform her?
Pulmonary embolism.
First, we will do chest X-ray. Chest X-ray usually shows signs of PE. B, CT pulmonary CTPA increases the lifetime risk of maternal breast cancer less than 10%. If the leg Doppler studies are not suggestive of DVT and clinical features suggest of PE, further imaging is necessary. The perfusion component of ventilation perfusion BQ test can be omitted to limit the radiation exposure to the fetus. BQ scan increases the risk of childhood cancer to 1 in 100 or 1,000, something like.
What? I was like, 1 million, so 6 number. Yeah.
Yeah. Usually shows sign
which one?
CT pulmonary angiogram increases the lifetime risk of maternal breast cancer by 10%. If leg Doppler study are not suggestive of DVT, the clinical picture suggests of E for the C doctor.
Yeah. If the
If
Doppler
leg Doppler
study
are not suggestive
and the clinical picture suggests
and clinical
further imaging is necessary. Yeah. Yes, this is the one correct. Yeah. But if the patient only for DVT, not pulmonary embolism, and you did ultrasound, duplex ultrasound, it is negative, no further test needed. If the patient only DVT, no pulmonary embolism. So you will ask the patient, you will discontinue the treatment, and you will ask the patient, he will come day 3 and day 7. But if you had high risk suspicion of pulmonary embolism, you will not leave the patient, not like DVT. Here, repeat 3 and 7, yeah, Dr. Dura. And if you had high risk suspicion or low risk suspicion, ultrasound negative, you will stop. But pulmonary embolism, if your suspicion low and ultrasound and this negative, okay. But if your suspicion is high, you will not discontinue the treatment and you will do other investigation. Yeah? I will show you, I think this one better remember the explanation to the answer. You want to stay شوية here or is okay? Okay, يلا go.
Can Doctor slide off the answers, please? Slide off the answers, please.
The answer is C, دكتورة. Okay.
Yes, thank you.
Yeah. Big scenario. What happened here? Yeah. Hello. Yeah. Where is Berfin? She's tired. Anyone to continue? Yeah.
Yes.
Anyone want to continue?
But I cannot get the.
I can read.
Yeah. يلا. Berfin,
Doctor?
57 questions.
Yeah, I can read. If
Yeah.
Doctor,
Anyway.
maybe Dr. Parvin got tired.
Tired, exhausted. Yeah. Where is she? I think.
Wallah, she.
Berfin, where are you?
She read nearly 30.
Yeah.
30 questions.
No,
she read. You want to continue?
Anyone, no problem.
Dr.
Anyone.
Parvin.
Berfin, Saima, everyone. يلا.
No, okay, I will start few questions and then again if any of difference.
Berfin,
Okay.
she will continue Saima. After that, you will take. Anyone.
Parvin, continue? Okay, go ahead. Parvin, continue.
We don't know. We had this
27.
Yeah, we in the middle, Dictora now. Yeah.
As the labor specialty trainee on call, you are asked to review a nulliparous woman who has been pushing for 80 minutes. She had a low risk pregnancy and has been aiming for water birth. She has made adequate progress and was pushing to be fully dilated 2 hours previously, but pushing has been delayed until she felt the urge. She is now out of the pool and the CTG was commenced. She is tired and no longer coping. On examination, she has an appropriate grown fetus with no head palpable abdominally. On vaginal examination, she is fully dilated with head +1, 2 spine in left occipito-transverse position with 1 plus caput and 1 plus molding. Glycer is clear and CTG is reassuring.
All the time, Mr. Bervin, in the exam, I want you to be very systemic. You will not forget any point. Tell me here, the patient, she is first you remember yourself. The patient, she is nulliparous or she is multiparous. Because you remember yourself for your time. Because you had limited time for any delivery. In the second stage of labor. The patient here nulliparous. She is how many times she is fully. And where is the head? Where is the station? After that, you will decide. We had 4 factors, the patient multi or nulliparous. Other thing, her time, it is finished or not yet. CTG good or not yet. And where is the station? 4 things. After that, you will answer any question. So you will be very organized.
Yes. She is nulliparous And she is pushing for 80 minutes. 80 minutes means for.
She's fully what time? She's the other
120.
scenario. You want from fully till now, how many minutes pass? After that, we can give the patient the FCTG normal more time or will interfere. Other thing, where is the head? Where is the station? After that, you will decide for your patient what you will do. See how she's fully how many time, because Nalibras her time what without epidural. Her time what Nalibras 2 hours.
She
2
hours previously.
Yeah, 2 hours
And
without
she's
epidural. She finished now her time or no?
Yeah, and
She's tired.
Yes.
But she's tired.
Tired, yeah, and the head +1. So what you will do?
Yeah.
Yes.
She cannot.
But occipital transfer, so we will trial
I
in
will
the
show you
case.
the option.
What is the management plan? Cesarean section, continue pushing, forceps delivery in the room, trial of instrument delivery in theater, venous delivery in the room. I will go with trial of instrumental delivery in theater.
Yeah. Correct, because your patient, she is telling you she is not coping anymore. And the head +1, the head is still high. And her time is finished. So you want to interfere, it will be by the instrumental in the theater. All the time, in this intrapartum care, remember yourself by 4 points. Patient nulliparous or multiparous. The other thing, her time finish or no. All the time, remember the time, she is multiparous or nulliparous, CTG good or not is good, and where is the station of the head, high or down. So you will decide. The question, it will be very easy for you. Okay?
Yes, sir. Yes. Which of the following condition can permit the use of either forceps or ventouse and not forceps exclusively? After coming head of the bridge, face presentation, occipito-posterior position, prematurity less than 34 weeks, suspected coagulopathy in the fetus. It is occipito-posterior position.
Yeah, this is yes, occipito-posterior position, because exclude, not forceps exclusively. Yeah. This, yes.
A 26-year-old gravid 2 para 1 at 33 weeks of gestation with monochorionic diamniotic twin pregnancy present with twin 1 in cephalic position, twin 2 in bridge position. The pregnancy has been uncomplicated to date, and both the twins are above the 50th centile of growth with no significant size difference. CTG has been normal throughout the labor. Twin 1 has delivered uneventfully. Twin 2 is breech but high up. Contractions are adequate, but 30 minutes has passed. CTG is now suspicious. Breech,
Yeah.
breech extraction.
Remember the new guideline, Dr. Berfin, they mentioned something about suspicious. If your CTG is suspicious and past 20 minutes, you can interfere. You will deliver by cesarean or normal. This is updating the new guideline. This means before you will wait for 30 minutes, but here they tell 20 minutes. If your CTG is suspicious, you need to interfere. Here, 30 minutes pass and CTG is suspicious. You want to deliver this patient. You will go to the theater or you will deliver by what you will deliver. See the option.
What is the optimum management in this scenario? Breech extraction, cesarean section, ECV and birth with ventouse cup, rupture of membrane and comments on syntocinon. Wait for another 30 minutes. Breech extraction, doctor?
Yeah. Because his other option, cesarean, why I will go for cesarean? I will try, but I will be low threshold. If I have a problem, because this baby breaths and 30 minutes pass and CTG suspicious, yeah, but I will try first. External cephalic version and with ventouse, rupture of membrane, commence into, no, the patient she had regular good contraction. Wait another 30 minutes, no, her time passed. Now we had 30, you can wait till 30 minutes if CTG good, and you can wait more 20 minutes if CTG suspicious. The new guidelines, they tell CTG suspicious, better you will go for cesarean in the reveal. CTG good, you can wait for 30 minutes. And you will interfere. I will do breech extraction. Yeah. Yes.
Dr. Husnia?
Yeah.
Dr. Husnia?
Yeah.
That one.
Doctor, you told this is intrapartum guideline, nice intrapartum guideline. There is limit of 20 minutes. When?
40 minutes? No.
Hello?
We had no 40 minutes, Victoria, now. Here in the Tanzania.
No, no.
Yeah.
No, I'm asking. Is the limit now 20 minutes?
If CTG suspicious, it is 20 minutes. If CTG okay, you can wait till 30 minutes.
Okay. When this guideline is released, is there any new guideline?
Yeah, this new guideline, I think in 2019 or which one? The new one. Before, you can wait for 30 minutes. But I tell here, the new guideline update, they tell better if twin pregnancy, not in single. In twin pregnancy and 20 minutes pass, and your CTG suspicious, the patient will not deliver, go for cesarean.
Okay. Dr. Husnia, once the session is finished, can you share this document with us?
Yeah, yeah. Okay, okay. But I will write note because you will tell okay and I will forget.
I have one more question.
Yeah.
Yeah. I have one more question. When there is a question with the twin pregnancy, there is always a question of either transverse lie or there is breach, the second twin. So in the when there is transverse lie, what is the best option, ECV or internal podalic version?
Podalic version, it is better. Podalic version, it is better. You can do internal podalic version or external cephalic version. Yeah,
yeah. So in the
podalic
better for the
podalic version is better.
Thank you very much, Dr. Husnia. Thank you.
Okay, yalla, let us go. Okay.
A 38-year-old para-zero woman attend an elective cesarean section for breast presentation. Her BMI is 32. Her mother and sister has both had a DVT in past. Post-operatively, she developed a swollen left leg and shortness of breath. On examination, the leg is blue with evidence of varicose vein bilaterally. The left leg is painful to move.
This is a full problem. Yeah.
What is the most operative next step management? Arrange for ventilation perfusion scan, arrange for leg Doppler scan, commence prophylactic Clexane, commence therapeutic Clexane, encourage to use it until further investigation. We will arrange for
See the
Doppler scan.
The question again, Dr. Vervi. Very clear what the patient she had. Very clear. Post-operative.
38-year-old.
Yeah.
Attended elective cesarean section for breech. Her BMI is 32. Her mother and sister both had DVT in past. Post-operatively, she developed a swollen left leg and shortness of breath. Shortness of breath.
Yeah.
On examination, with evidence of varicose vein bilateral. The left leg is painful to move.
You will wait and you will do ultrasound, and you will do Doppler, or you will put this one, or commence prophylactic, or you will do therapeutic. What? Because the picture very clear.
Therapeutic.
Yeah, start therapeutic. The patient she has a very clear diagnosis. No need to do. Start therapeutic, Alexa. Yeah. Therapeutic dose. Yeah.
Can I say again? Question. A 38.
Mother and sister.
Without doing investigation, we will start.
Very strong history and the patient. And the picture very clear. The patient. When the examination, the leg is very swollen. Evidence varicose vein bilateral. Patient she starts short of breath. You not waste the time, Dr. Berger. Short of breath, خلاص the patient she will be DVT and pulmonary embolism. Please, doctor, mute yourself so the record, inshallah, will get benefit from it. Can you mute, doctor, yourself? Can you mute? Yeah, clear now.
I'm sorry. The answer is obvious.
Yeah. She had recent surgery. She had very strong history. خلاص, and the picture from the scenario very clear. The patient, she had DVT. So I will start. After that, I will see what I will do. But I will start. I will not waste the time. Okay.
As a senior ONG specialist training, you are supervising a junior colleague who is performing a cesarean section in second stage of labor, following an unsuccessful attempt at operative vaginal delivery. Your colleague has some difficulty with delivering the baby, and you immediately take over the procedure. You are unable to disinfect the fetal head from the maternal pelvis.
The impaction. This is a second stage cesarean section. There is a head very impacted, and he tried to deliver the baby. He cannot. Yeah, we had two problems here. We had it's mentioned very clear, Dr. Nerveen.
What should you do next? Ask the assistant to perform vaginal examination and apply direct pressure to the fetal head over the posterior frontally. Continue attempt to disinfect the fetal head from above. Perform J or inverted T-shaped incision, identifying the fetal foot, and perform breech extraction. Request that the on-call consultable and wait for their arrival. Use the forceps blade to disinfect head by the scoping the head.
Yeah, we mentioned this one yesterday. Second stage section. If he will do from down, if he will deliver, he had 4 methods. And here you see all the options that seem not correct. The first one, ask an assistant to perform direct apply pressure. No, it will be this more problem to the baby. It will not be direct. Yeah, you will put fetal below, or you will take from up. This A not correct. Continue attempt to impact the fetal head from above. It will not come. If the head is impacted, you cannot take it like this only. Perform J and inverted T. Yeah, as I mentioned this one. You can do the 4 methods for this one. Yeah, pull or push or bat Wardan technique or fetal below. And if the baby not come for you, you can perform J or inverted T and deliver the baby. But you will not wait for the consultant to come. We had emergency. If you wait for consultant, baby will die. Use forceps blade to this one, it will not come with you. So the correct answer, it will be C.
Perform J and
yeah, it is mentioned in the guideline. Yeah, it is mentioned in this one. Nice guideline, sir. The second stage is nice. Why not? Who's asking? Why not A? Ask an assistant to perform direct in the head. You will have problem to the head. We will not do direct. We had 4 methods to do this one. Not direct, by fetal below. Yeah. Okay. Oh, you deliver the baby by breech. Yeah. You remember push, pull. There is you deliver the baby by breech, pull muscle. I have not seen the previous message. Doctor, she asked about it. Okay. You want to explain more the previous question, or it is okay? We can proceed. Hello? Proceed. Okay. Okay. Yeah.
A 30-year-old woman excisional biopsy of her cervix for high-grade change on colposcopy for background of high-grade dyskeriosis. She has no comorbidities and does not want to have children in future. The histology shows invasive adenocarcinoma extending to 7 mm in depth and 7 mm in lateral dimensions. The excisional margins are clear. Radiological investigation revealed no lymph vascular space invasion, no lymphadenopathy, and no metastatic disease.
طيب Mrcog, all the time remember yourself which stage, so you remember how you will treat. Which stage this one? Remember 7 millimeter.
More than
7
7.
millimeter what? If we had 1A, it is less than 5 millimeter. So we exceed 1A. Now we are 1B. صح? 1B1, remember 1B1, 1B2, 1B3. 1B1, remember me 1B1, 1B2, 1B3. Where is the patient now? The patient, yeah. After that 1B3, how we will treat? In the exam, remember like this. First stage, after that, remember the treatment to any stage. So you can answer.
This is 1B2.
Yeah.
More than 5 and less than 3?
1B3.
Less than 2?
More than 1B1.
Which is
1B1.
more,
And the patient, she had
more
no
than
wishes. Also see the other scenario. She had no wishes for future children in the future. You will do what?
radical.
Yeah, radical. I will give you the option. It will be radical hysterectomy. Plus what?
What is the most appropriate advice regarding how management had for the excision biopsy using leads or other technique? B. Have a radical hysterectomy, pelvic lymphadenectomy, and oophorectomy. C. Have a radical hysterectomy and pelvic lymphadenectomy. D. Have a radical trachelectomy and pelvic lymphadenectomy. E. Have an external beam radiotherapy followed by brachytherapy and chemotherapy. She will have radical hysterectomy with
patient fit for surgery. Patient she had no problem for surgery. Yeah, and only certificate.
No, she have no
comorbidity. So it will be radical hysterectomy plus and pelvic lymphadenectomy. Yeah, all the time in the exam, take the cancer first. After that, you will see the treatment. It will be easy for you. I am printing this is staging and this is near me all the time. I am watching, so I will not forget. Yeah, because all the time you read the cancer, and when you go outside and come, خلاص, it will be finished.
Yes.
Yeah. She had no wishes also the patient for any future children, and the patient fit for surgery, and the cancer not 1A or not 1B1, it's 1B3.
You are labor ward specialist trainee called to assist low risk multiparous woman in labor who is 40 weeks of gestation. Fetal membrane rupture prior to the onset of contraction 12 hours ago. Full dilatation was diagnosed 2 hours ago, and there has been 1 hour of active pushing with descent of presenting
Doctor,
part.
there is many echo. If anyone, this one, mute yourself all, it will be good. Because we need to revise this session after. And some not attend, we need the record. Yeah. Yes, now it is okay, Pervin. Continue.
Yeah, full dilatation was diagnosed 2 hours ago, and there had been 1 hour of active pushing with descent of presenting part. Diamorphine was given as analgesia 3 hours ago. You examine and reveal that the fetus is in cephalic position with 0/5 of the head palpable abdomen. You confirm fully dilatation. The fetus is in direct occipital anterior position with no caput or molding of the fetal head. The presenting part is at station +2, that is 2 centimeters below the ischial spine. The fetal CTG is pathological with baseline tachycardia more than 180 per minute and atypical deceleration.
Yeah. طيب, analysis all the time. Remember, there will be another to analyze.
Yeah.
ETG pathological. And where is the head? And the patient finish her time, not finish. Pathological, خلاص her time, not her time finish. Pathological, I want to interfere. I want to deliver the patient. Where is the head? Where is the station? Yeah. +2. That mean low. I will give you the option. And the CTG more than 180.
Low.
Pathological.
What is the most appropriate management given for the above finding? Cesarean section continue active pushing and reassist in 1 hour. No non-rotational forceps delivery, non-rotational venous delivery, rotational venous delivery in the operating theatre. See, doctor, non-rotational forceps delivery.
Yeah, because very down the head loss too. CTG pathological. Yeah, yes, correct. No rotation ventus, observation ventus. Because the head down and no cabot, no molding. Maybe this is the reason. See any explanation to this one? If there is cabot, if there is molding, I cannot do. Yeah, and the head very down. For example, and CTG good. What is the? And direct occipital anterior, no need for rotation. And the head down and CTG pathology. I choose ventus. But usually I am choosing forceps because I am afraid for failure, and after that I will.
Dr. Husnia, regarding this question particularly, I remember before for the previous exam, we were discussing with our mentor, Dr. Sidra. Dr. Sidra clearly mentioned when the scenario is like this case, always she said, use, if there is no contraindication for ventos, she said always use ventos for. That's why I was in doubt. I was going to choose D, but when I saw all the friends, she said whenever you can do ventos, she said use ventos.
No molding and the head down and CTG pathology.
Yes, exactly.
Yeah,
she said always.
But for
I
me,
remember,
I used to all the time I am thinking maybe ventus it will not come. Pathological CTG, but then I will go for the other one. But head down and direct occipital anterior. You are not need any rotation. And CTG pathological head block too. Very helped by ventus it will come. So I agree with ventus. Yes. Yeah, correct, Simon.
Doctor, can you show the question slide, doctor? I will take one. I will take the. Previous,
Yeah, CTG tachycardia more than 1 minute, and atypical deceleration, CTG pathological, and head bloss too. Yeah. This intervention care very important. Inshallah, they will give 8 questions. Yeah, very important.
Dr. Husnia, I'm so sorry, I missed this part. Why we use ventus again?
Because the direct anterior, and she had no cabot, no molding, and head bloss too. You can use ventus, you had no problem. You are not afraid to this one, the ventus.
Exactly.
Head very down, bloss too. Need a little help. It will come. And direct anterior. You are not
if there was a caput.
If there is caput, if there is molding, if you need some rotation, okay. But it's direct anterior. It will come by ventus.
Dr. Husnia, I read some. Whenever there is fetal distress and abnormal pathological CTG, we have to choose forceps delivery.
Yeah, it is better for you. If you are afraid, because if you had cabotedictoria, or if you had molding, and CTG are very bad for you. You are afraid you will do ventus, and after that you will do sequential and instrumental, you will afraid. But here I am not afraid, no need for any rotation. If they need rotation, really it will be forceps. But here no need for rotation. The baby direct occipital anterior, and the head bloss too, and CTG pathological. It will come with you by ventus. This is the time you use ventus. But if you are afraid any other, you need some rotation. Baby right or left or occipital posterior, you can use. But here, this is the ventus indicated here. Question strata وجي دكتورة. Strata يا دكتورة إيمان. Most of it from strata. Okay? Yeah, let's go.
A 30-year-old woman had a second trimester miscarriage at 19th gestation. The baby was growth restricted with polydactyly in the upper limb and cleft lip and palate on the external examination. Post-mortem examination revealed features of haloprosencephaly and ventricular septal defect. This is trisomy 80.
Yeah, 13. It came also in last exam. I remember the picture of the Fatih is sending in the group. You remember the finger and the eye is close together and all this one. Yeah.
Yes,
Came
in
last,
January exam.
yeah, 2021 also we had Batao. And I think 19 they bring Edward. You will not go for exam without Edward and Batao and Down syndrome. I remember the screening. You revise, yeah, revise the screening before you will go, inshallah. The screening for Down. I remember the picture of Edward and remember the picture for Batao. It will come, yeah. Turner also, yeah. Turner. Turner remembers the echocardiography. Maybe she will not conceive also. She can go for IVF pregnancy and the cardiac problem. Last exam, Dr. Dua, they bring one patient, Turner. She will conceive by IVF pregnancy and she had cardiac problem. They ask which one it will be. Down or Turner? Yeah, yeah.
Okay.
Well, this one. Yeah, it is Turner in last exam. So this exam it will not come Turner. This exam for Edward or Down. But Down in each exam. Yeah. Yeah.
A 35-year-old woman, Parapo, complained about many years of urinary urgency, frequency, and occasional dribbling after passing urine and pain when she passed urine. She also suffered quite badly with painful sex. A vaginal examination reveals a tender mass 3 centimeters inside the anterior vaginal wall.
What is your impression, Dr. Berbi? Before I will give you the option, what is the problem here? Recurrent UTI, painful, and dyspareunia. What is this picture show? Painful sex, she had dyspareunia, and she had UTI, recurrent UTI, and she had tender in the vagina when you examine the patient. Yeah.
Occasional treatment.
I will show you the option.
Yes, a 35-year-old Parapo complains of fluctuating cystogram, mid-extreme urine culture, MRI, renal ultrasound, rigid cystoscopy, dribbling of urine.
Rigid cystoscopy.
Where is diagnosis? What is your diagnosis? Alzheimer or Berberin or other? What is the diagnosis here? Dyspareunia and recurrent UTI and tenderness in the vagina. What is the diagnosis? Very typical.
I thought it's diverticulum. Urethral diverticulum, doctor.
Because the tender in the vagina and all the time, most important picture. Dribbling and you will treat the infection because she had like pouch. It will come in the pouch and it will be more infection. So we'll which one? Micturating cystogram or midstream urine culture? Culture no need. An MRI scan, renal ultrasound, not ultrasound.
Cystoscopy.
It will be cystoscopy.
Cystoscopy.
You had two options, MRI or cystoscopy. But cystoscopy, it is double balloon. Double balloon ureterography. This is a gold standard diagnosis for this one. And it can be MRI. Here I had no double balloon ureterogram, so I will choose MRI. Yeah. Gold standard.
It should be what, doctor?
Double
it should be what cystoscopy? Oh, double balloon.
Double balloon.
0 degree.
Yeah.
0 degree.
The gold standard diagnosis of diverticulum. But here we had no, we can choose the MRI. Yeah. Okay. The option on MRI. Yeah.
Sorry, doctor.
Yeah.
Dr. Husnia, Assalamu alaikum.
Alaikum assalam.
Sorry, why not rigid cystoscope?
Not rigid. Not rigid. they diagnose by double balloon. Rigid, it will not diagnose to you. Because remember, diverticulum, it look like what rigid, it will not diagnose. If you had double balloon, it will be okay. ما في double balloon, it will be MRI. Okay?
Okay, thank you, doctor. Thank you.
Okay.
A preliminary analysis in 50 women in study group. The BP of 23 women has dropped, but 13 of them developed drug-induced hepatitis. Again,
See how many? You had 50 study group, and 23 women has dropped, but 13 of them developed drug-induced hepatitis. Here you have drug. The result, it will be what the study, it will be randomized controlled trial. But 23 of them have developed induced hepatitis. This came in 2021.
no benefit, no harm, unethical study should.
This is repeated recall question also. Yeah. Read Parveen. Finish بعدين الكيوز.
No benefit, no harm. Unethical studies should be terminated. Convincing evidence of harm, convincing evidence of benefit, a trend of benefit with consent of harm.
See. See better.
Can you please show the question again?
The 23 women has dropped, but 13 of them developed drug-induced hepatitis. All they are 50. From this 50, 13, they had this one, drug-induced hepatitis. 13 developed كتير from 50, 13 from 50, this induced hepatitis is a big problem to this one. This patient, unethical study, unethical. Should be terminated. You cannot continue the study like this. You will terminate this study. You will not continue. You will not say all it is harm or benefit or concern. You will terminate this study. You will not continue. Okay? Because 13 out of 50, it is big number. Yeah?
Yes, doctor. Yeah. Yeah.
A 34-year-old
Ma'am, when can we call this convincing evidence of harm, and how much harm should be called as actual harm?
Because if you had little problem, you can think about any other option. But if problem like this, it will be not ethical. You want to terminate now. 13 out of 50, it is more. It is a big number. So you will not continue. But if you had a little number, maybe you will neglect and you will continue your study and you will see. Because complication, it can be in the study, drop it will be in the study, but not big number like this. Big number like this, you will terminate. You will not continue. But if you had a little problem, and you will get some benefit from this study, you can continue little, but this one, no, not acceptable.
Ma'am, but how much should we call as little, or how much should be called as more?
Yeah, if you
is there any limit for it? I mean,
number,
any
patient
exact
list.
number is there?
Yeah. What? Yeah.
Ma'am, is there any exact number from like beyond 5%? We should call it as the
your study, because they had rule for the any study. They had rule any study. Like this, they will terminate. Like this, you can continue. Some problem, some drop out, they will do. They in the research in the this one, and they are taking from the GMC. The rule for any study, you cannot do like this, because you will suppose this is the life of patient. Hepatitis not something is, and 13 over 50 is big. This one you will terminate. But if there maybe there is some, they had rule in this study, not like anyone he can do a study and he will continue the study. You will take first the permission, and also that they will give you some rule for your study. If you will follow the rule, the study like this, you can continue. But if you study, it will make more harm to the patient. They will terminate. They will not accept for you to continue a study. If you will get benefit, if you will not get benefit.
Okay. Thank you.
A 34-year-old woman present to the labor ward with contraction and spontaneous rupture of membrane with vaginal bleeding. On examination, abdomen is soft in between contraction. CTG is as follows.
Yeah, she had bleeding and abdomen soft. Yeah. What is this better in Barfin?
This is sinusoidal pattern, doctor.
It's probably severe bleeding, or so it's showing fetal anemia, severe fetal anemia, sinusoidal pattern.
Yeah, sinusoidal pattern is fetal anemia. What you suggest the patient she had bleeding? I will go back to the scenario. Rupture of membrane. What will happen after rupture of membrane? Very vasa brevi. Yeah. Who will remember the exam? September we had some question from vasa brevi. Who will remember the question to tell us so we can? Saima, can you remember us about the exam vasa brevia in 20 September? Hello? Yeah? Hello? Hello? You can hear me?
Yes, we can hear.
Yeah. No one remembers this one.
Yes.
I remember you. The patient, she is 29 weeks. This came in September 20. The patient 29 weeks, and she ruptured the membrane, and they diagnosed vasa brevia. They ask you CTG good. They ask about the action. You will go direct for cesarean, or you will give DEXA and you will wait for 24 hours, or you can wait. She ruptured and diagnosed vasa brevia. You will deliver the patient, or you will wait, give DEXA and wait 24 hours.
No, we will go directly for cesarean section because vasa brevia, doctor.
Vasa brevia cannot wait because you will remember you vasa brevia, the baby blood very little. If he bleed 100 ml, it will be affected, and fetal anemia is fatal, so you will not wait. This came in September. Yeah, correct. This is the sinusoidal pattern that indicated hypoxia. It will come like fetal anemia by vasa brevia, by bleeding, or by, you remember, parvovirus also. It came in July 19. They give tracing like this, and that time the CTG parvovirus. They ask what is the indication. They give the infection, listeriosis, parvovirus, and syphilis, and other infection. And they ask, they give some tracing like this, around 20 or 30 minutes. Parvovirus also the picture same like here. Vasa brevia is same like here. Yeah. You will not wait to give DEXA. They give you in the scenario in the September CTG is good. They maybe you will think you will wait to give DEXA and wait. And baby extreme preterm. No, you will go for cesarean before baby die. Because the blood of the baby very little, look like 300 only. Yeah.
Site of xylocaine injection for paracervical block. At what clock? 139-261, 2357, 411, 4 and 8.
Yeah, which clock the paracervical block? This is a poll question.
I remember to B, doctor.
Which one? B? 261? No, not 261. I think Michigan 16, 16. Yeah, E, 4 and 8. طيب, who will remember if you had preterm and head intrap? The answer 4 and 8 was 4 and 8. 4 and 8, yeah. If you had head intrap after deliver, after coming head, you will
Dr. Husnia, similar to this 4 and 8 incision on the cervix, similarly endorsing incision for the head entrapment in breech. This is the same location we do incision? when the
head
breech head is
incision.
yes 4 and 8 yeah
No, ما في 4
those incision.
No, if you had head
No?
incision, ما في 4 and 8. Tell me. Yeah. Because you remember when we are discussing Justin Konji in Justin
Yeah, the 4 and 8.
yeah.
No,
You
wait. It was.
It is mentioned in Justin Konji 3 and 7. Yeah.
Yeah. Let
Just
me
think,
see.
it
It was
mentioned 3
similar.
and 7, but not 3 and 7. I tell you not 3 and 7. Tell me what. Anyone to tell me the correct answer? Yeah.
Before they use,
Yeah, 2,
no,
6,
no,
and
not
10.
3,
Who
because
mentioned
3 is the side of the
2,
arm.
6, and 10? 2, 6, and 10.
2, 6, 10.
Yeah, yeah.
Yes, yes.
Sorry, 3
Okay,
and
okay.
9. 3 and 9 to be avoided. 3 and 9.
Two, doctor, repeat, please.
Area. This is the vaginal
Dr.
artery.
Husni,
Yeah.
2, can you repeat?
2, 6, and 10.
Because
2,
everything
6,
is
and 10. Yeah. Avoid.
Okay.
You will 2, 6, and 10. You will give the incision here. Avoid 3 or 9 and 9 because this is the vascular area. This is the vaginal artery. You will not put the incision.
Exactly.
Remember, 3 or 9 mafi or out. But 2, 6, and 10. Yeah. Paracervical block 4 and 8. Yeah.
Okay.
Yeah, yeah.
Yes.
Question?
You want the question or what?
Yeah, just 1 second. Question because I missed the question.
Okay, okay.
Yeah,
Not
okay,
D.
okay.
The answer
this
is
was
E. I make it D and E, no.
Okay, thank you. Thank you.
Doctora, the cervical incision 2, 6, and 10?
10, 2, 6, and 10. And they mention in the guideline
Okay.
avoid 3 and 9. 3 and 9, this is the area that is very vascular. You will be bleeding. This is the vaginal artery. Okay?
Okay.
Yeah. What is?
Can we go for 4 and 8 as well for the cervical incision for breech extraction?
Which one, Dictora? I cannot hear you well. Yeah?
For breech extraction, for after coming out of the breech.
Yeah.
Is 2, 6, and 10 the only option, or can we do 4 and 8 there as well?
4 and 8, this will do cervical block. But 2, 6, and 10, this is the place to do the incision.
Okay, okay.
Because in the preterm, the head is big and the body small. Sometimes the body deliver and the head trapping. So he will incise 2, 6, and 10, and you can do cervical block 4 and 8, and avoid 3 and 9.
Okay, yeah.
Okay.
Why we have two answers here, 4, 11, 1, and 4 and 8? Why? Why we have two answers here?
This mistake. The answer 4 and 8. Not to answer. The answer 4 and 8 cervical block. Yeah, by mistake this one. Maybe I am sleeping that time. Yeah. Okay. Not to answer. How come to answer? Yeah.
A study was conducted between two groups using two different mesh techniques to see the effect. What suitable test? This is Chekhov's test.
Why?
Yes.
Yeah. Why? Tell me.
I
am remembering you say repeat till you will clear. Why chi-square?
2 into 2 table, doctor. That's I remember. 2.
Yeah.
And
Remember,
2 different.
Yeah. 2. Remember where are you? Remember, Dr. Barbie, because you are the man asking about statistics. A statistic here.
Yes.
We had here. We had this variable. Yes, Dr. Categorical. And in the middle we had numerical. And the right side we had this categorical. Mesh, it is categorical. صح? It is not number. And 2 group. Yeah, it will be mesh technique. It will be chi-square. Remember 2 group.
Chi-square?
Between 2 group using 2 different mesh technique. Mesh technique and 2 group and categorical data. It will be chi-square. I remember you before, we had 2 group. Chi-square, it can be 2 group or 1 or 3 group. Yeah. Chi-square, because Whitney and over all this one, the parametric test and numerical, you cannot choose T test, Whitney test, all in the numerical that ANOVA. If you will comparison parametric test and 3 group, so it will not be here. All this categorical, you will choose the chi-square. Yeah.
70-year-old woman has had debulking surgery for ovarian cancer. What standard adjuvant treatment would be recommended for this patient?
Yeah, you remember ovarian cancer? We had in last exam 3 MQ about ovarian cancer. They asked one about the chemo, they asked other one about follow-up. I forget the other one about what. 3 MQ in the 2021. Yeah, I will give you the option. Debulk surgery for ovarian cancer, what is the adjuvant treatment?
A combination of platinum for 6 months and radiotherapy, Plexitel and carboplatin for 6 cycles, Plexitel and carboplatin for 3 cycles, no. Plexitel and carboplatin for 6 cycles and radiotherapy.
D. D.
Yeah.
D for boy.
Yes, D.
For 6 cycles.
Yeah, D.
Paclitaxel and
carboplatin. It will be 6 cycles at the same.
Okay.
Yeah.
If you are interested in finding out which type of anesthesia is more comfortable, please be read out. Which repeat and anesthesia is more comfortable for the patient perspective for using during cesarean section, epidural or spine? Which type of study would you think is most appropriate to help you to answer your answer more effectively? RPC. This is a difficult question.
You will tell me. You will, whatever you will choose, you will tell me why.
Doctor, I remember the guess.
Yeah.
The password only.
Yes,
Ask
read the question
RPC.
again. So, this Barfil, I want to tell you something. All the time, I will remember I had 4 men study in front of me in the exam. Remember, I write case control study. Alas, write cohort study. Write cross-sectional study, and this one, randomized control trial. It has this 4 main study. By exclusion, I am choosing. I am doing like this. Case control something immediately. Case control retrospective. Cohort prospective. This one, randomized control, you had treatment. Now you see you had treatment or no. Other one, cross-sectional, now. Any something you will do it now, and you'll take the preference this cross-sectional. So you will not be confused. Here we had treatment, epidural, spinal, like this. Which one it will be treatment? The other one, no treatment. Retrospective, it will be in the past, not effect in the front. Cohort, it will be prospective, and it will take long time to observe. Cross-sectional, it will be now you will do it now, and you will take the, like, remember, cross-sectional fibronectin and preterm labor. You will take now and you will do. So if you will put this 4 in front of you, by exclusion, you can guess which is one. Yeah? You had treatment. Yes. What you had in the question? What you had? I want you to. You had anesthesia. You had treatment. You had observation. You had epidural, spinal. Like this is a type of treatment. So it will be randomized control. Yeah. And this is a stroke impedance in casualty. It will be randomized control. And remember, great top guideline randomized control trial. Yeah. Yeah.
A 34-year-old woman with type 1 diabetes is 7 weeks pregnant. In her first bump pregnancy, what will be an indication for placing her on insulin pump?
Mafi pump in her first pregnancy. And this is a question that I think is not written correct. 34-week-old woman with type 1 diabetes and she is 7 weeks pregnant. In her first pregnancy, what will be indication for placing her on insulin pump? What you will 7 weeks, and she's diabetic, and diabetic type 1. which indication she will place you to put her in the insulin pump. Also, this recall question. This July 19. See the option. What time we will put the patient in the insulin pump? There is stock. I remember me. I will post in the group. Insulin pump. It came in the exam before, and there is stock. Insulin pump. Yeah.
She has a high hemoglobin A1C that need to be reduced early enough to prevent increased risk of congenital malformation. She is suffering from hyperemesis gravidarum. She is able to achieve adequate blood glucose control with multiple daily injections, but is experiencing occasional significant debilitating hypoglycemia. She is suffering from Down phenomena, requiring an increased dose of insulin for short time in the morning, early morning. This one, Dr. D. She will suffer from Down syndrome phenomena.
Yeah,
C.
because you cannot control. Yes, this you because if you will do sliding scale, if you will increase, it will decrease like this. You want something to control for you this one, so it will be by insulin pump. Yeah, correct. We had to. We can revise after the session. Inshallah, I will post. Read it because it came in the exam before. We had insulin pump. So, yeah. Increase the dose of insulin for short time in the early morning. The pump it will regulate for you because you cannot by sliding scale increasing, decreasing. Will adjust.
Doctor, why the option is not C, doctor?
C, what is C? She is able
if
to
she's
achieve
not able to achieve. Oh, she is able to achieve. Sorry.
Yeah. Here more the down for
Got it.
Yeah.
I got it.
Yeah. Okay. Long scenario. What happened here?
With previous one cesarean section followed by successful vaginal birth is seen to the labor ward at second stage of labor. She is 41 weeks pregnant and her labor has progressed well in first stage up to 8 centimeters to full dilatation. She has been pushing effectively for 1 hour. On examination, there is fifth of the head palpable abdominally. On vaginal examination, the vertex is occipito-transverse position with 2 plus occiput and reducible caput.
Plus 2 caput, I see. Plus 2 caput, reducible. She had reducible molding and plus 2 caput.
The vertex is at the level of ischial spine and CTG is satisfactory. Here we will do CS, doctor. Ischial spine, head is very high.
Yeah, the head very high and the patient risky. And she had 8 centimeters. She is multi. 8 second stage of labor. She is 41 weeks pregnant and her labor has progressed well in the first stage up to 8 to full dilatation. She is 8 centimeters to full dilatation. She take how many? Effectively for 1 hour. On examination, the fifth of the fetal head. The patient, she had previous one cesarean section. And she is still here after fully dilatation. And the head is still high. Patient risky, will afraid, transfer, deep transfer, rest of the head. Patient multi, usually if she is be like this, everything is good, no malpresentation, she will deliver. So, you will not apply, you will not take the risk. It will rupture uterus if you will try. Yeah, you get the money?
Yes.
The vertex in occipito-transverse position. Occipito-transverse. She had some problem here. So she will not deliver this patient. If you will try, she will rupture the uterus. Risk patient. And previous CS, very easy to rupture. And multi, usually, if she had no problem, she will progress fast. She will not stuck like this. There is something wrong. Yeah.
Seems to be need rotation also, so this is very dangerous.
Yeah. Which one you will
This is grade 1.
Grade 1 or grade 2? Yeah.
Grade 1.
Why grade 1?
Grade 2.
The CTG, Dr. Barmin? They mentioned anything about CTG?
Normal.
Yeah, CTG normal. It will be
grade 2.
75 minutes. Yeah.
CTG normal, grade 2.
Grade 2. Yeah, CTG normal, grade 2. You'll not do. If CTG abnormal, we'll go for cesarean section grade 1.
Grade 1.
Yes. Yeah.
Great.
Very risky patient. Don't take the risk. Be safe, doctor. So they will pass. Okay.
A patient presents with symptoms of prolapse. On examination, pelvic organ quantification score is A0, B0, C minus 5, D minus 7, AP minus 2, BP minus 2. And transvaginal length is 9, GH is 4, PB is 3. The patient wants her prolapse to be treated surgically. What is the correct diagnosis and surgical treatment?
Yeah. We had the prolapse, we clear the prolapse, right? No one, he will not make this question correct. Ferris, what Dr. Berberi will tell me the stage in Ferris. Which stage is this one? And you will remember us by stage before we will go. Which stage? Which stage the patient Ferris? See the anterior vaginal wall, the posterior vaginal wall. She had anterior or she had posterior. And which stage?
This anterior vaginal wall, it is near the hymen, doctor.
Yeah.
0.
Yeah, in the 0. 0, which stage? Remember me from the stage Ferris. It's stage 0, what? Stage 1, what? 2, and 3, and 4. Remember me by the stage. And after that, anterior vaginal wall or posterior vaginal wall. And after that, you will tell me the treatment.
If I remember.
Yeah.
Stage.
You will remember.
Stage 1.
We make a separate session for this one, sir. Yeah, they will remember.
Yes.
Yeah.
Stage 2 cystocele. Stage 2 cystocele.
Stage 2 cystocele. Yes, correct. Because why? Because A0. You remember stage 2 between minus 1 and plus 1. Minus 1 plus 1. Minus 1 plus 1, it will be 0. So it will be stage 2. And the patient, she wants surgical treatment. You may remember prolapse stage 1 and 2. It can be by pelvic floor. But the patient, she wants surgery. Anterior, that means cystocele. You remember when we come for the treatment, cystocele will be corrected by what surgery? Yeah. Anterior repair. Yeah, stage 2, cystocele and cystocele anterior repair. Correct. You are good now in the prolapse. I will show you. Yalla, remember this one. Don't forget in the exam. Anterior vaginal wall, A small. Posterior vaginal wall. We had total vaginal lenses. Remember, this is the total vaginal lenses. This is the anterior wall. This is the posterior wall. Anything above this one, minus 3, this is the stage 0, normal. Between 0 and minus 1 and plus 1, above minus 1, this is stage 1. Stage 2, between minus 1 and plus 1. Minus 1 plus 1 is stage 1. Everything after plus 1 will be stage 3. If you want to differentiate between 3 and 4, total vaginal length is minus 2. If less, it will be grade 3. If more, it will be grade 4. Yeah? Remember this one in the exam. Last exam, no BABIKER. This exam, it will be there. BABIKER. Okay? Clear? Yalla, go. No clear? You want Dr. May? I explain to you? You want explanation or we'll go? Okay, yes, we'll
We need
explain. Yeah.
Just explain it again, please.
I will explain, my dear, because we had session about this. I think it is clear, no problem. We had, see here in the picture. This is the hymen. Hymen is 0. This is the point I will decide from here. This is the hymen, is 0. We had this one from here to here. Make this A small anterior vaginal wall from here to here. A small anterior vaginal wall. Here from here to here. Make the A small anterior vaginal wall. B small posterior vaginal wall from here to here. This is the cervix, it will be C. Pouch of Douglas, it will be D. and you will from the cervix till the hymen. This is the total vaginal lenses. Total vaginal lenses from the cervix to hymen. Doctor, there is many background. Can you mute so I can explain? It's okay now. Okay, we'll start from the start. Maybe you are not hear me well. We have, this is the hymen.
Doctor?
Yeah.
Dr. Husnia?
Yeah.
Please explain this TVL again, this total vaginal length problem again, please.
I am explaining, but after the mute, inshallah, you will hear me well. Okay. Start from the start. Here, we had this hymen here, 0. Here, 0, the hymen. You can see here, the hymen, 0. I will make a small anterior vaginal wall. This one, a small anterior vaginal wall from here to here. Here we had posterior vaginal wall from here to here. This is the posterior vaginal wall. This is the cervix, very clear in the picture. This is the cervix, and here is the pouch of Douglas. If you take the uterus, hysterectomy done, this point will not be there. It will be omitted. Total vaginal length from cervix till the hymen. Here, this area. From the cervix here till the hymen here, this is the total vaginal length. Here we had genital hiatus here, and this was a perineal body. Okay, clear? This is perineal body. This is the genital hiatus. This is anterior vaginal wall. This is the posterior vaginal wall. From the cervix to the hymen, this is the total vaginal length. This is the cervix, and this is the pouch of Douglas. If you do hysterectomy, pouch of Douglas, this point will not be here. Then you will come to anterior vaginal wall. The proximal part, it will be A capital. The distal part will be B capital. I will go to the posterior vaginal wall. The distal part, it will be an A capital. And the distal part, it will be B capital. This point, A3 and B3, this minus 3, and it will be mirror image. And this one more than above minus 3, the BA, above minus 3. Anything above minus 3 will correct. We had no prolapse. Anything, it will come down from here till plus 1. From 0 to out, this plus. From 0 in, this is the hymen, 0. This is 0. If anything inside, it will be positive. Anything from hymen outside, it will be positive. So I can determine. See, the the staging of this one, if minus 3, it is normal. This is the normal place, and it will be mirror image. This mirror image, and above minus 3. Plus 1, this it will be stage 1. The uterus start to be down. Minus 1, it will be stage 1. Between minus 1 and plus 1 here, it came out little. Plus 1, minus 1 here, and 0 in between. You see, if our case here, 0 here in the hymen. Plus 1, minus 1 inside, plus 1 outside, and 0 here. This will be stage 2. When I will go stage 3, it will be more than plus 1 out, start to become out, more than plus 1. But you will differentiate stage 3 from 4. Total vaginal length is this one, from the cervix to the hymen. Minus 2. If less than the presenting part here, it will be stage 3. If more, it will be stage 4. And 4, all the uterus outside, all prolapse outside. This is residential. Uterus all outside. Okay? Okay, yalla, let us go.
Thank you.
Thank you. Here is stage 2, cystatil anterior repair. You remember, anterior repair, it will be with mesh or without mesh? Posterior repair with mesh or without mesh? I want to know, the session is still there or out? No. Without, yeah, without mesh. Yeah, without mesh. Yalla, go.
Can I see the slide of question, Doctor, please?
Yeah.
Slide of question.
Okay, very good.
Thank you, Doctor. You can move the slide.
Okay, okay. And
45, a 20-year-old primey, gravida 1 para0, present with papular and nodular rash on the face, neck, and chest at 14 weeks gestation. The papules are erythematous and some of them look excoriated. Her mother suffered from hay fever.
Neck and face. All the time I am remembering the face. You remember the picture? Yeah, I am remembering the picture by face and neck. Yeah. Which one?
Interruption of pregnancy.
Yeah?
A.
Yeah. All the time remember the picture. Anyone remember the picture?
A 50-year-old woman attends the general practitioner surgery with abdominal distension, lower abdomen pain, and urinary urgency. Abdominal examination is unremarkable and urine dipstick is negative. What investigation should be performed?
55 years, more than
attend the general practitioner surgery with abdominal distension,
abdominal bloating. I remember the bloating and distension and more than 50. Yeah, we'll give you the option.
Examination is unremarkable and urine dipstick is negative. What investigation in urinary tract? Full blood count, no investigation, reassure pelvic ultrasound and scan, and serum 125. Pelvic scan, doctor?
No, Mervin. You remember it is mentioned very clearly.
CA125.
You will do a scan. But which one is first? You will do
CA125.
Yeah, because blue.
CA125.
And after that, you can do ultrasound. Yeah, but first, CA125. It is mentioned. If the patient she had bloating and her age more than 50, first thing remember CA125. Yeah.
CA125.
Yeah. It is mentioned again. Yeah. No, first you will do CA. If the patient like this, the scenario they mentioned do CA125, and after that we can do ultrasound. And if we had after that we can we'll do the risk of malignancy and we'll see. But first CA125 mentioned very clear.
With regard to squamous cell carcinoma.
Ma'am, can we please discuss the previous question again?
Yeah, okay. 1 minute.
Actually, CA125, this is not the exact tumor marker for the ovarian malignancy only, na? Because it can be raised in the other conditions as well. Before knowing that she can be a probable candidate for the ovarian malignancy, we should get this scan done first, na?
No.
Because if we have to calculate the RMI, we have to have the ultrasound features as well as CA125.
Tell me, I will listen to you first. After that, I will tell you. What? Yeah? Yes?
Ma'am, I'm saying if we have to calculate the RMI, we have to have the ultrasound features also as well as the CA125.
Yeah, because of
CA125. Because it can be raised in the other conditions as well, other than the ovarian malignancy.
It can be raised in the other thing. And this patient, if she had abdominal distension, abdominal pain, because they are thinking will be irritable bowel. They mention very clear in the guideline, if the patient above age of 50 and she had this one abdominal bloating, abdominal, first one, do CA125. If it is high for you, proceed for ultrasound. Mentioned by this sequence.
Okay.
Yeah, first this
Dr. Husnia? Yeah, I have a similar question to our colleague. She's asking. I had similar doubt actually. I thought, because I know the patient in the clinical picture, she's having bloating and she's postmenopausal, but I think in the clinical aspect, we do pelvic ultrasound and then Because that is a very good marker to start. Is there something wrong in the ovary, in the appearance, in the cyst or
Saima, if patient like this, usually I will do ultrasound. I will not think about the serum 125 with patient elder. But really, in the
In the
guidelines, it's mentioned like
postmenopausal,
this. Post-menopausal,
in postmenopausal
everything.
age, 125 is first.
I have medicine.
Okay.
Premenopausal
I can tell for you. It's mentioned very clear. Do CA 125.
Okay.
Here, it will come after the session. I am writing my note today. CA 125.
So Hannah, if I hope it come exactly same this question in the exam, and you pick up.
I think it will go for where this one, but in the guideline it is mentioned. If the patient, I will see which one. I think in the pelvic pain, something like this pelvic pain. I will post for you. I am writing here. Give me time, Shway.
Okay.
But mention like
CA
if the
125.
patient she came bloated or abdominal distension and she's elder than 50, is do CA 125. But actually, yes, CA 125 is increasing in many conditions. Yeah.
Yeah, even in endometriosis is one of the conditions that is right. Yeah, in so many conditions. Yeah.
The guideline is 25, and after that you decide.
Okay.
I think it is mentioned.
Yes.
Let me see, and I will.
Thank you. Yeah. We should follow the guideline.
The guideline is very strict. It is correct or not correct.
Okay.
Because not our graph.
Yes, that is the point, Doctor.
You
are right. That is the point. Yes.
Yeah.
Yes, we should follow the guideline.
Our
That's right.
graph is very different, so we are like this.
Very different. Yes.
I just want to add something.
Yeah.
For the CA25, it should be done at a primary level. Like before they send it to the hospital, the GP, because this woman is postmenopausal.
Yeah,
this is the first point. So she's not seen at the hospital first. She is seen in the GP with the bloating, with the abdominal distension, and this. So the CA25 will be ready when it be in the primary. So that's the thing. So C115 is done first. Okay. Thank you, Dr. Husnia.
Yes. Please mute. I want the record for others. Mute.
With regard to squamous cell carcinoma of the cervix, what is the minimum time span between the infection by HPV and development of pre-malignant lesion with true malignant potential? Number.
Number included in the number.
1, 5 years, 8 years, and 7 years. 7 years?
7 years, yeah, correct. 7 years. I tell from this infection till the patient she will get the cancer, it will be 7 years. The potential time, 7 years.
How many questions of this percentage will come in exam? Do you have any idea about it?
From the report. From the repeated report. Yeah. No, ما في million. No, ما في a lot. شوية والله. Before they are sending many questions from this one percentage, but now all from the report. خلاص, revise, recall. I will tell Dr. Fatih to continue recall till the exam. If he will not do, I will do till the exam. So we will finish the SBA question.
What numbers are coming in recall, that only they are keeping?
Yeah.
What numbers are coming for, that only we have question.
8 घंटे में मिलियन क्वेश्चन सॉल्व करके आएंगे.
Dr. Husnia, can you see this question?
I will show you
the question. Yeah.
उसके लिए परसेंटेज रिटर्न को लिखा मिलियन.
All the SBA from the recall. We will recall till the exam.
Okay.
Inshallah. All the SBA report. The figure. Yeah.
Okay. Sorry. Thank you.
Yeah, now we'll do. Dr. May will do. We'll do recall till the exam. I promise you. I will see Dr. Fatih. If he will not do, I will do for you. This is gift from me. Yeah.
So, what is the answer, doctor, for this question?
7 years.
B.
7 years. Yeah.
Thank you.
Yeah.
अबे यार दूर रहिए, गर्मी वैसी ही है.
Mute.
You are preparing to switch. Following a process delivery during the ear, complaining of numbness around the mouth and the shortness of breath. Drug toxicity.
You are preparing to suture a perineum, following a forceps delivery by infiltrating the area with xylogate. When the woman is
% higher.
Please, doctor, mute so we can hear. Please, doctor, mute yourself. Yeah. Read it again, Dr. Pervin. Read again.
You are preparing to suture a perineum following a forceps delivery by infiltrating the area with the lignocaine when the woman starts complaining of numbness around her mouth and feeling short of breath.
Numbness, they immediately will remember.
Administer intramuscular adrenaline call for help, like the woman flat. Perform observation plus BP. No, stop infiltrating the anesthesia. Doctor?
Yeah. Ferris, if you had any toxicity, you will stop the drug Ferris, and after that you will see what you will do. And here from local concentration. Ferris stop. After that you will see what is the problem you can bring. If patient collapse,
Dr. Husni, you remember in our January exam we had a similar question. After epidural, top up epidural. Yes.
After
the patient got with the symptoms.
Patient become hypotensive and same scenario like this.
Exactly, hypotensive and then
you will cause. Sometimes maybe they will ask you the diagnosis. This one is diagnosis, it will be drug toxicity. If they will tell you what is your first action, it will be stop the infiltrating anesthetic. And there is test here. Anyone remember the test to tell us? There is one test of this one, drug toxicity, local anesthetic. You remember the test?
I don't know. No.
Muscle. I think muscle tryptase, something like this.
Muscle tryptase.
Yeah, muscle tryptase, something like this. Tryptase, I think. There is test very specific to this one. This is a maternal collapse. Yeah. Tryptase.
Muscle tryptase.
Yeah.
Doctor, will there be any break, or you will continue, doctor? Will there be any break?
We had only 2 questions. After that, we'll discuss about the exam, any hazy point. After that, we'll stop the session. We had only 2 questions remaining. We'll finish.
Okay, doctor.
After that, we'll open discussion. If any doctor she want any point about the exam, we will tell. And after, inshallah, it will be in the group. If you had anything, I can help you. No problem. What is after stopping? You will give interlipid antidote, doctor. Interlipid antidote. After that,
20%.
Collapse, you resuscitate as usual. The fluid, this one, adrenaline and all other. But antidote for local, this one, interlipid 20%. Okay?
Yes.
Yeah.
What is the most common cause of maternal collapse is cardiac preeclampsia, epilepsy, hemorrhage, pulmonary embolism. Maternal collapse, no? Epilepsy, doctor?
Collapse, remember collapse, Dr. Darwin. If collapse, it will be epilepsy. طيب.
and cardiac arrest.
Collapse, it will be epilepsy. خلاص. Indirect
cardiac arrest, it will.
Indirect, it will be cardiac. Indirect, it will be cardiac. Overall, cardiac. Collapse, epilepsy. And what then we have VTE. صح? VTE something. What VTE? Indirect cardiac. Indirect cardiac. Overall cardiac. Collapse, epilepsy. What about VTE? There is something VTE. Remembering.
Cardiac. This direct.
Overall.
This is direct.
Direct cause. Yes. Direct cause VTE. Indirect cardiac. Overall, cardiac. Maternal collapse, epilepsy. Yes?
And maternal death, maternal death.
Maternal death.
Most common cause of maternal death.
What is maternal death? Because we had all these.
If it's a direct cause or
Direct,
indirect? If it's direct,
if indirect, it will be cardiac. Cardiac.
Cardiac.
Yeah.
Cardiac.
And in the cardiac is MI and
MI and
arrhythmia. Yeah,
arrhythmia.
the most common reason of cardiac problem.
Both.
MI and arrhythmia. Yeah. MI and arrhythmia.
Yeah, last exam.
Arrhythmia.
كله last exam we finished the last exam. Yeah.
Yeah. Last exam this question.
Last exam we finished. I think last exam all from the strat. You see most of this question strategy.
I didn't notice, Doctor. Most from strategy. Okay.
All came from strat. We had cardiac questions in the
strategy.
Yeah. Yeah. Allah.
A 60-year-old with genuine SI, PFMT failed to improve her symptoms. She denies surgery. Which drug can be given to her? Oxy, paradoxin, doloxetine, doloxetine.
Yeah.
Yes.
So usually, you remember our session, stress incontinence mainly the treatment what? Surgery. But if the patient refuse surgery, it will be doloxetine. It is not the first line, it is not the second line. But if she is not fit for surgery, she had any comorbidity, or refuse the surgery, he will give her doloxetine. Yeah. Yes, correct. You remember the surgery for stress incontinence? Anyone to tell me the surgery, what I will do?
The surgery?
Yeah.
Whether a sling method?
Same level other than colpo suspension.
Or colpo suspension.
Yeah.
Or a sling.
Yeah.
Sling?
Yeah,
Yeah.
sling.
Both are effective.
Yeah.
Autorectal sling or mesh
sling together in the same line is colpo suspension, and
or
after that mid-urethral sling. Yeah. Yes. Yes. But if they will ask you which one, autologous or colpo suspension, because in the same line they mention this or this, and inshallah they will not give the two options in the same question. But if they ask you, yeah, you will go direct to colpo suspension. Number one, colpo suspension.
Okay.
Because now no more sling. Sling كتير مشكلة.
Okay.
The problem came in 18 and update in 19. Yeah. I remember.
Okay.
Yeah.
Because of erosion, Doctora? Side complications like erosion or
bowel, intestine, fistula, all pain, severe pain, not tolerated by pain, all this one. They make the problem in 18 and they start to in 18 and update in 2019. They make some restrictions.
And if
yeah.
Okay. And in colpo suspension, if both options are there, laparoscopy and open, we will choose open, yeah, because not laparoscopy everywhere they have enough experience. Which one the answer? Open or laparoscopy colpo suspension?
They ask you laparoscope. Laparoscope is the topic to the same. Laparoscope is the topic.
Okay.
Yeah. Because less complication and less hospital stay and
better recovery.
Better recovery. Thinking all the time about the patient, the cost and everything. This one laparoscope if they will ask.
Laparoscopy we will choose.
Yeah. Yeah. ما في break دكتور ما will finish because I came from duty today وعبارة الله.
والله God bless you, Doctora. That's
let's sit 1 minute.
In the hospital and mustashfa and then you back.
Yeah. But really, if anyone he wants any query about the exam, better explain now before we go. I had nothing to do. And in the group, any query, any talk, any problem, it will be together in the group.
Dr. HUSSNIA, I have always, if just a question, I know it will come, this question is a very regular in the exam, about the timing that when the patient is on the low molecular weight heparin.
Yeah.
How many hours before the cesarean or normal delivery? How many hours? Is 6 hours, 12 hours, 24? I always confuse. And I know usually this come in the exam. Or after epidural, how many hours? Can you just briefly tell a key point of that?
Let me write. I will write for you, not Simon, because usually
Okay,
stop
very good.
24 hour if you had therapeutic, and 12 hour if you had prophylactic, and after epidural, after 4 hour you can remove the epidural. And what else? Remember therapeutic 12 hour.
Dr. Epidural,
Prophylactic
tell me
12 hour.
please.
If you had trauma, you will not remove before 12 hour, and usually we remove
Which one?
after
Which
4
one?
hour. This one
So
is
you mean
remove after epidural.
when we have top-up epidural, so or no, when we remove the catheter, when we will put the 12 hours?
Yeah, 12 hour epidural.
After the removal.
Insertion, yeah. And if you had therapeutic,
12
you will 24 hour. I will write you notes, Simon. Let me sit after.
Okay, thank
you. I had my note here. Dr. Simon, she wrote this one. And I will send the talk for the insulin pump. And what else, Tani? I had something to send.
No chance.
Yeah. And
there is no 6 hours, Doctora. In the
one more
options.
thing.
Yeah, okay, you tell.
Hello.
Dr.
Yes, yes.
No chart.
Hi.
Hello, Dr. Husnia.
Yes, Doctor. Yes.
Can you please explain question number 29 in which we did breech extraction for the second twin? I'm not clear with that.
Because if you had, breech, Doctora, usually you remember the time in the previous guideline, you will deliver the first twin, and after that, if you were the head for you very down and it is cephalic, you will rupture and then you will deliver the baby. And if they also breech very engaged, you will deliver the baby. And they are limited by 30 minutes. After 30 minutes, you won't interfere. This before. The new guidelines, they mentioned 20 minutes if your CTG suspicious. Be very threshold, low threshold. If CTG suspicious and head high for you, and you can try, you will deliver the patient. If she is not delivered, go direct for CS. This is mentioned in the guideline. But here, we had two options. What you will do? Baby breech. You will do external cephalic version, or you will do internal budalic version. And they are telling internal budalic version. Internal budalic version, you will, which please is new? Let me write for you here to see. The twin, and I will show you this 20 minutes. I will send for you, Doctor. All this point I write. And if CTG 20 minutes suspicious, he will go, he will try, he will give threshold. If patient deliver, he will deliver the patient by internal budalic or external cephalic. Whatever near for you, you can deliver.
Ma'am, but in this question, they have written that 30 minutes have passed. So
I will send for you. I will send. I know this one. 20 minutes suspicious CTG, you will do for cesarean. I write in my note now here. After take rest, I will post in the group. Okay. Anyone have any new candidate for the exam this time? July?
Ma'am, question. Dr.
Yes, Doctora, me.
Who?
Yes, Doctora, please tell us about the exam.
Yeah.
Please.
What?
Yeah, Saiba.
Doctor, tell the story of the exam.
Yes, Saiba, she will tell you about the exam.
A story.
Yeah.
A story about the exam.
Yeah.
Dr. Husnia, the association between Down syndrome and smoking, how can you please explain? It was case control study. Can you please explain that?
Because you will patient deliver Down syndrome, Doctora, the baby Down. Okay, we mentioned we had 4 types of study. We had randomized control trial. This one, if you had the treatment, if you give treatment, it will be randomized control trial. Okay, this out. Who is right is option by exclusion. This out. And we had this one cohort. Mainly, it will be prospective study. You will observe, you will not give any treatment, and you will take long time and you will observe. Here we mention this case control because why? Patient deliver down. We will go back in the history and you will see, because case control, it retrospective study. Go back in the history and see. What I will see? I will see this patient deliver baby down. I will compare in the history, in the past, and I will take the history from the patient. Is he smoking during this past, till her history till she delivers this baby down? I will take her from the history. They tell here there is bias. The result maybe might not correct. The patient maybe they will not tell you the truth. Because history, you cannot get all the point what you want. And you will go back and you will see, is this smoking affect the baby and deliver down or no? From the history, from the back, you will go back and see.
Okay, Dr. Husnia, thank you so much. It's clear now.
Okay, Yalla, tell me, who is new in the exam? Anyone new in this July exam?
Yes, Victoria.
طيب, the exam now it is computerized and not difficult. By computer it is very easy. Really it is time, يعني it will save for you the time. We had 2 papers in the exam, paper 1 and paper 2. And in the exam you need to pass the paper separately. If you pass this one and this not pass, you will not pass the exam. You need to pass separately. The first thing, paper 1 we had 50 question SBA and 50 question EMQ. This is paper 1. Paper 2 we had also 50 single best answer and 50 EMQ. Some doctors, some mentors, they are telling, if you want better, you will go for a EMQ, finish the EMQ, and after that come to SBA. But from myself, better for me SBA. Why? I will tell you. Some doctors, they better tell finish SBA after that, because they will give you paper 1. This one, and after that you will take break 1 hour. And after that you will come the second paper. Every paper we had 50-50, 50 SBA, 50 EMQ. I tell you, some doctor prefer to start by EMQ and come back by SBA. But from my point of view, better SBA. Why? I will tell you why. Because SBA all from the recall. Most of the SBA from the exam, it is recall question. Recall question because we are recalling, you will remember. And the EMQ, most of the EMQ new scenario. Like this one, early pregnancy module or intrapartum care or VTE, and the scenario in the exam very long, not like short in the EMQ, not short like here in the recall. Scenario very long. If you will start from here, you will forget here when you will read. So better you remember in your mind the most important thing. مثلا, if they will give you intrapartum care, you will see the gestational age, how old, the station where, and all this where. In the exam, last exam, I asked for papers. They give me paper, and so I am writing my note. Dr. Saima, she told me they are not give the paper and pencil. But for us here in Saudi, they give paper and pencil. You can write your note. For my side, better you will start by SBA. Because if you will start EMQ, if you will start EMQ, it will spend a long time, and actually I'm not finish the SBA. Also, it be a problem for you because your brain it will be busy. So, for me, better I will finish the SBA very fast, and I will come to EMQ to take the time, because EMQ it will take your time, and the time it will come very fast in the exam. Be organized. Don't be in the stress. You will finish the question. And gynae and obs it is mixing the same paper. Same paper mix obs and gynae. 50-50, 50-50. You will finish here 3 hours, 3 hours, and they will give you gap 1 hour. And in the exam, it is computer system, very easy, not very difficult, nothing in the computer. They will give you the option and you will click. And also you can do flag. Any question you had doubt, like question number 80, 82, I am not complete, I can do flag. It will appear for me in the screen. Very clear for me, this one I am not did. This one it is remaining for me. So I can go back and answer it. And you can revise. I think you can revise twice, no problem for this one. You can take it twice. You can read very fast. But the question you are not answer, make flag, and after that come back answer. And after that, if you have time, you can answer it. Do like this. Any question? Hello?
Hello?
Had any query about the exam? Yeah.
Yes, Dr. Husnia.
Yeah.
You tell in the first you have to pass one paper or something like this. I didn't
to
hear.
pass any paper separate. If you pass this one and this paper not pass, you will not pass the exam. Any paper separate.
Like previous, يعني.
Yeah, and 50-50. 50
I think they change, يعني.
No,
because
not
in
change.
MCBCH not like this, يعني.
No, not change. 50 SBA and 50 AMQ. Some doctors they prefer to do the AMQ first and after that the SBA. But for me, better I will do the SBA first, so I will not be busy mentally by SBA. And after that, I will start AMQ. Yeah.
Thank you.
You had any query, anything you want to
bless
ask?
you. No, thank you.
Okay, doctor.
Yes, doctor, I want to ask you, there is a thing I cannot remember. This is for the patients for prolapse or things, they are more exposed for urine retention. How we are going to be sure that they are not in urine retention? We are going to give them, I think this comes in step, right?
What is the question, Sarah? Tell me. Yeah, the patient, she had prolapse and she had urine retention?
Yeah, after correction of the prolapse.
Yeah.
This is the people who are going to keep the catheter in them, right?
Yeah, you will keep
We have to examine them before. We have to examine them before removing the catheter, right?
Removing the catheter, yes. Yeah. You will keep the catheter and you will examine before you...
We are going to for 1 week before we try to remove it.
Wallahi, Sarah, I am not remember exactly, but I think something like this. But I am not sure to tell you. But you will keep the catheter like this, yes, correct. Yeah.
Thank you, doctor. Thank you.
Yeah, inshallah, we'll be together in this one in the group, and Dr. Fatih will continue the recall. We'll record our recall because the SBA all from this one. If you'll spend 1 hour, 2 hours daily, it will be good. Because most of the SBA we can this one it will finish by the recall. We need to repeat the recall and recall till we'll go to the exam, inshallah. And if any query, anything, inshallah, we'll post in the group. And all the best, inshallah. Okay. Yalla, thank you to all. Thank you, doctor. Thank you.
A lot of thanks, Dr. Husnia. Thank you. Appreciate your offer.
Inshallah, ya Rab, ya Rab. All prayer. All prayer.
All the best for you, doctor.
All the prayer for all of us, inshallah. All prayer. Yeah, inshallah. God bless all of you.